Good afternoon. I'm Deborah DeVoe. I'm the Chair of the Health Policy Commission. On behalf of my fellow commissioners, let me welcome you all to the Massachusetts Health Policy Commission's 10th Annual Cost Trends Hearing.
I'm not
We
sure.
appreciate those here who are,
Can you just pull it up?
sure, who are attending in person for the first time in 3 years. Last time we held the annual Cost Trends Hearing in person was fall of 2019. You remember that, just a few months before the pandemic changed the world dramatically. Thank you to my fellow commissioners and to the representatives from the Center for Health Information and Analysis and the Office of the Attorney General for your participation today. We're honored to welcome Governor Charlie Baker, Senator Ed Markey, and virtually Attorney General Maura Healey. This is not my first attendance at a Cost Trends hearing, but it is my first as chair of the board, having been appointed by Governor Baker in July. I thank him for the honor, and I'm glad to be with you today and to take up this work. I also want to thank Executive Director David Seltz and the HPC team for preparing this event on behalf of the Commonwealth. And welcome to all who are joining us online. I want to start with a few words about the environment and the realities we face in charting a path forward in access to high quality, more affordable care. What has changed in the 10 years since Chapter 224 was enacted, and what do those changes require from us? It's clear that in the 10 years since Chapter 224 was enacted, the law has had significant impact. Following the establishment of the healthcare cost growth benchmark and the HPC, healthcare spending growth in Massachusetts moderated and was below comparable national trends for most years. However, the challenges to affordable, accessible, high-quality healthcare in Massachusetts have changed, and the issues we're facing in 2022 are very different from those of 2012. In 2012, we were focused on utilization as a major driver of healthcare costs. And in order to change incentives for potential overuse and misuse, the key solutions that we identified were value-based contracting and demand-side incentives, meaning that health plans and providers would focus on creating contracts that rewarded improved efficiency and quality, and that benefit plans and cost sharing for patients would align their financial incentives in seeking care. As we look back in 2022, the data tells us that price is now the most significant driver of increased cost and spending, rather than utilization. The data also shows that value-based contracting and patient incentives have had a more limited impact than we have hoped. Additionally, since 2012, there are new factors that are driving cost. The proportion of healthcare spending on pharmaceuticals and other biologic treatments and therapies has increased, reflecting important advances in innovation, but also the increasing price of existing drugs and new drugs. Other factors that impact health system performance include the role of hospital outpatient centers, increasing provider consolidation, and significant enrollment in high deductible plans and increasing premiums. So the data and facts tell us that the drivers of spending in 2022 are much different than in 2012, and the significant headwinds of major staffing issues, inflationary pressures, and the continued impact of COVID-19 are changing how we think about the actions that are possible to improve how healthcare is delivered and financed. The focus of our hearing today is charting the path forward. How should Massachusetts balance the upward pressures on costs that are challenging healthcare providers and health plans with the affordability challenges facing consumers and businesses in the Commonwealth? This question and these challenges are not unique to Massachusetts, but perhaps Massachusetts is uniquely positioned to chart a path forward for two reasons. First, in the past 10 years, we've built a sophisticated state data infrastructure to understand what is driving healthcare spending and support a fact-based dialogue. And second, our providers, health plans, employers, and government have a track record of working cooperatively on policy solutions that have had an impact. This annual Cost Trends hearing gives us the opportunity to consider and reflect on the data and evidence, engage with healthcare leaders and stakeholders, and our hope for today is that we identify and discuss actions to take us forward. I want to sincerely thank all stakeholders for your participation and commitment. Now I want to turn the program over to our Executive Director, David Seltz, to walk us through some logistics for the afternoon.
Good afternoon, everyone. Thank you, Chair DeVoe, for those opening remarks, and welcome to your first cost trends hearing as Chair of the HPC Board. Don't worry, you don't need to be sworn in when you sit on this side of the table. To all the HPC commissioners, thank you for your service and your participation in this landmark event, the 10th annual Healthcare Cost Trends Hearings. It's so great to be back together again in person here at Suffolk University. I'm also thrilled to welcome all of you here in person today, and for those of you who are watching on our live stream, for anyone here today who attended our first ever Cost Trends Hearings at UMass Boston 10 years ago, we do have a special prize for you. You get a hard copy of our Cost Trends report at the front desk. Please pick it up on your way out. We're being serious. Thank you. In addition to the incredible, esteemed state and federal leaders we're about to hear from, I also want to acknowledge the joint chairs of the Healthcare Financing Committee who are with us here today, Chair Lawn and Chair Friedman. Thank you for being here, and thank you for the important work that you and your committee staff to lead the development and passage of healthcare legislation in Massachusetts. Specific congratulations on a successful legislative session this year, including the passage of comprehensive legislation to remove barriers to essential mental health services. I hope you will convey our gratitude to Speaker Mariano and Senate President Spilka for their ongoing commitment to advancing healthcare policy. Additionally, want to thank and welcome Representative Christine Barber and legislative staff from across the State House that are here today too. Just a few quick logistics and reminders. Materials for today's events, including the full agenda of the day and all of the presentations, are available on our website, and including a program book. In addition, I do want to point out that an important part of this hearing happens ahead of time. In advance of this hearing, we solicited written testimony from 28 different healthcare organizations. We asked these organizations about the challenges that they're currently facing, the strategies they are employing to rein in healthcare costs, and the policy solutions that they would recommend to the state. Those responses are posted online on our website, and we encourage you to review those thoughtful responses. We are also accepting testimony from the public. If you would like to submit written testimony, please email it to hpc-testimony@mass.gov by 5 p.m. on this Friday, and we will post all written testimony to our website. Lastly, we are also live tweeting today's event, so please be involved with us at the hashtag CTH22. As Deb said, this is truly a unique public event, an opportunity to engage in a dialogue with experts, key stakeholders, leaders of our healthcare institutions, to identify policy solutions and to commit to shared action and accountability. To kick off today's conversation, I am very pleased to introduce Secretary Mary Lou Sutters, an inaugural member of the HPC board, first appointed in 2012 as the behavioral healthcare expert. Thank you, Madam Secretary, for your continued leadership as an HPC board member and as Secretary of Health and Human Services for the past 8 years, and for the partnership and collaboration throughout. And if I may, I'd like to particularly congratulate you and the governor on the recent successful agreement with the federal government to expand and extend the state's 1115 waiver. In the immortal words of now President Biden, this is a BFD. The waiver agreement is a groundbreaking achievement in Massachusetts, particularly due to its nation-leading focus on health equity, and by a goal of closing disparities in quality and access. And oh, did I mention, it's just worth about $67.2 billion to Massachusetts. Madam Secretary, I know you don't like the word transformational, so I will say it of my own accord. Congratulations, Madam Secretary, and to you, Governor, on this transformational achievement for the Commonwealth. Thank you, Madam Secretary.
Good afternoon, everybody. The governor and I can probably fill in that BFD, but we will not since we're live streaming.
All day long.
Yeah. Sometimes we do. It is my extraordinary privilege to introduce someone who needs no introduction in this room. He is a lifelong resident of the Commonwealth of Massachusetts. Governor Charlie Baker is the 72nd governor of the Commonwealth. Sworn in the first term, January 2015. He will step down in January 2023. Over the course of his career, Governor Baker has been a highly successful leader of complex business and government organizations. He is truly the one who deserves the thanks for the 1115 waiver of the Commonwealth, because he is the one who sets the standard, the bar, and the expectations of what we are to deliver in the executive branch. Don't worry, Governor, I'm going to be very brief because you haven't done my performance evaluation yet.
Thank you. Yeah.
He is one of the most popular elected officials in the United States, and I know he's more popular than Santa Claus, so I know who to give my Christmas list to. But in all seriousness to all of you, he is the person for whom whatever gains have happened in this Commonwealth and this executive branch is because of the governor's extraordinary leadership. Governor Baker.
Well, thank you very much, and I'll see you all later. Thank you, Madam Secretary. We all know this is a team sport, and I'll leave it at that. To the members of the commission and to the chairwoman, Deb DeVoe, it's nice to see you in that seat, Deb. I look forward to your tenure as chair. I want to thank you for having me today to speak at the 2022 cost trends hearing, and I'm especially pleased that we are able to do this one in person after doing it virtually for the past several years. There are a few themes I'm going to talk about today. I'm going to talk a little bit about COVID and the impact of a prolonged pandemic on our healthcare system. I'm going to talk somewhat about behavioral health, and I'm going to talk a little bit about some of the underlying cost drivers, and I will say a few words about the waiver, because what the heck, we might as well celebrate it since it's here and it's with us, and it provides a ton of unique opportunity. I want to start by saying that over the course of the past several years, I think it's fair to say that our health system here in Massachusetts, around the country, and around the world has been put to the test as never before. And I can say there's no other state I would have wanted to be in for the past 2.5 years, given the challenges that we faced. And I say that with the full understanding of the loss and the heartache and the tragedy and the disruption that far too many people experienced throughout the course of the pandemic. I do want to say that Commonwealth Fund, which is a fairly well-known healthcare research institution, did a study on how all 50 states dealt with the pandemic. And they used 56 measures to determine how states fared, and Massachusetts finished just a little bit behind Hawaii, but significantly, Hawaii and Massachusetts finished significantly ahead of the rest of the country on the overall scores. And I do have to say, because I just have to say it, that, you know, Hawaii is an island. We're not. They have much better weather than we have, and we are the third most densely populated state in the country. And there's no question that density and COVID had a lot in common with one another. I also do want to point out that there were several national studies that were done on the transparency and the ease of use associated with CARES Act funding by state. And several of the studies, every study basically said Massachusetts did as good a job as anybody of making the data associated with how we put that money to work available to the public. There was one study in particular that I thought was pretty thorough, in which they had a top tier of 6 states, one of which was Massachusetts, which they ranked as exemplary in the way we distributed and produced information on how we were putting CARES Act money to work. I think the state and many of the institutions that are represented by this group showed tremendous grit and nimbleness throughout the course of this pandemic. And we were on phone calls basically every day with most of the major healthcare players and a number of municipal and state officials. And the amount of sharing that went on during that period of time was extraordinary. And I think a lot of that had to do with the fact that everybody realized the challenges we were facing and the crisis that was in front of us. And I have to say that at every level of government, whether it was first responders and EMS professionals or folks in the long-term care community or people who were part of our community and academic medical centers. Every single day, people were managing their own anxiety and working their way through it as best they could. And I think, frankly, the performance in Massachusetts relative to most other states was demonstrated time and time again throughout the pandemic. And I just also want to mention that while most of the rest of the world shut down, the healthcare community didn't have that option, and they continued to respond to urgent and emergency circumstances, as well as all the issues that came with COVID all the way through it. Many of our healthcare providers, from small group practices to our community mental health providers to our largest academic medical centers, were challenged like never before. And in the middle of all that, we also wrote an executive order on an emergency basis that created telehealth in Massachusetts for the first time because a lot of people were uncomfortable going to see their clinician. The irony, of course, is that telehealth was invented in Massachusetts, but we never affirmed it in state law until 49 other states did. It's true. And over the course of the next year, there were over 1 million telehealth visits in Massachusetts. And one of the more interesting statistics that came up out of this was the typical cancellation rate for appointments, especially in the behavioral health space, is somewhere between 20 and 25% for in-person visits, for a lot of different reasons that I think everybody here would know and understand. The cancellation rate for telehealth visits was less than 5%. And I think it did prove in a very significant way that telehealth is an absolutely important part of the puzzle here. And I continue to believe that on a go-forward basis, we will see more of that in the future, and that will be a good thing. Over that period of time, there were a whole series of tools that were developed for dealing with COVID, many of which, a lot of the original and applied research associated with them were done here in the Commonwealth, which have made it possible for us to manage this more effectively. And at this point, between vaccines and boosters and therapies and treatments, we are in a far better place than we were a year ago, and especially 2 years ago. And as we move from a pandemic to an endemic, I think we know that the healthcare system will continue to be tested in a variety of ways, but a lot has already happened. There's been a significant amount of lost revenue. They've had tremendous staffing challenges, which are having huge issues on both capacity and on throughput. And I want to emphasize this issue about throughput. We tend to think about our healthcare system as a set of different provider enterprises based on the licenses they carry and the services they provide. The thing we should remember about staffing shortages, especially when they apply almost across the board, is the impact that has on the system's ability to actually move somebody from the level they belong at to the next level to the next level. And there are real care consequences associated with that, but there are also cost consequences associated with that. Since most providers get paid based on a fixed amount for a particular service, if they have to carry somebody significantly beyond the length of time that you would normally carry them because they are no longer, quote unquote, that level of care, the challenges that creates financially for those organizations are pretty severe. And I do think the staffing issue is not just, you shouldn't just think about the staffing issue as a challenge for each particular part of our system. You should also, because that's real, but you should also think about what it means to the system's ability to behave as a system when they end up in a situation like this. And I think the MHA study was pretty clear. We currently have somewhere around 20,000 vacancies in the hospital system, not counting the steward healthcare system, which would probably add another 5,000 vacancies to that number. And there are really significant vacancies at every step along the way in the process. And that will create, has created, and will create going forward challenges for everybody in the space. And it's going to require some really careful and imaginative approaches to deal with that. One other thing I want to say about that is the travelers. I don't think you can fix the traveler issue at the state level. I think it probably requires some sort of a federal fix. But it has become, in many cases, sort of a standard operating procedure for a lot of organizations and a lot of individuals. And I hate to use anecdotes to make a larger point, but I have met people who are travelers here to Massachusetts from other parts of the country, and one of the questions I've asked them about their calendar and their schedule is, well, what happens to the place you live when you're traveling? And the answer is, it's being occupied by somebody from some other part of the country who's traveling to where they live and is staying in their house or their apartment while they are here providing services to us here in Massachusetts. And apparently there's a fairly big mini version of what would look sort of like a swap shop online that makes it possible for a lot of travelers to communicate pretty effectively with each other around the country, and to perpetuate this challenge, to make it easier to perpetuate this challenge even after we get past the point where I might say the emergency that we once faced is not quite like what it once was. But there are many institutions that are still dealing with shortages that translate into travelers, which translate into 2x and 3x what you would expect them to be paying for the services that they're providing. And I would urge this group to think about how to engage the federal government on this issue, because I don't know how to solve it at the state level, given the interstate issues that are associated with it generally. I do think we've been pretty good at putting about $1 billion in federal funds under the American Rescue Plan to work to deal with some of the issues associated with recruiting and retaining high quality healthcare workers. About $640 million of that is being used to support rate increases for home and community-based providers, as well as fellowships and loan repayment programs. And we've also focused on building the healthcare workforce through that 5-year federal waiver that David mentioned previously. I still think there's a lot of work we're going to need to do in the years ahead with respect to this. And there's a lot of reasons for why we're where we're at, but this one is not just a challenge here, it's a challenge pretty much everywhere across the country. And I don't think it's going to get better by accident. It's going to require some intentional decisions and some intentional efforts to get from here to there. We have and will continue to provide a variety of flexibilities to many of our provider organizations so that they can maintain capacity without compromising safety, given some of the issues that they're dealing with. I do want to talk a little bit about mental health. The pandemic also spotlighted, by the way, the last time I testified in front of this committee live was when we filed our behavioral health law in 2018. And at the time I said, we had a crisis in mental health and behavioral health and addiction services. Well, that one is clearly in a different place today than it was when I last spoke here. It's worse by a lot. And I think one of the things we did manage to come up with some interesting ways of supporting our behavioral health community and our addiction community during the course of the pandemic, but there's a ton of work that needs to be done here. And I think the pandemic not only spotlighted some of the issues we had there to begin with, but definitely exacerbated them. And today, as we come out of the pandemic, there are far too many people who are struggling to deal with the consequences of the pandemic, whether they be isolation, depression, or anxiety, and it's very complicated to access services that can help. MHA's report also talked about the fact that on a daily basis, close to 25% of ED beds in the Commonwealth have been occupied by patients awaiting behavioral health care services. And we have, by the way, a lot of behavioral health care beds in Massachusetts that are licensed and ready to go and not staffed. That continues to be an enormous challenge in that space as well. I think it might be as many as 400 inpatient psychiatric beds are currently offline, not because they aren't licensed, not because they aren't available, but because they aren't staffed. And that's why we're following through with many of the commitments that we made to prioritize behavioral health, along with our legislative colleagues and the Attorney General. A big part of that effort began with the rollout of the roadmap for behavioral health care reform, which started several years ago and included significant investments in our community-based programming. And it also includes the upcoming launch in January of 23 of the clinical 24/7 behavioral health helpline and 25 designated community behavioral health centers across the Commonwealth. This is stuff that we've been working through with the legislature for the better part of the last 3 or 4 years. And then finally, I did sign a comprehensive mental health bill. I gladly signed a comprehensive mental health bill, which was a big priority for both the House and the Senate and the administration that came through in the waning hours of the end of the formal legislative session. It takes many steps to expand access to mental health services. First, it creates new requirements for commercial health insurance and mass health to cover behavioral health services. I learned a lot about behavioral health services when I was at Harvard Pilgrim. I learned a lot more in my current job. And there are a whole variety of ways in which parity has remained an elusive goal over the course of the past decade, despite a lot of people's best efforts. And I think we nailed down a number of the most significant issues there, which once implemented, I believe, will make a big difference and move us much closer to a truly parity-based system for mental health services. And some of the things that were incorporated into that were annual mental health wellness exams and treatment for behavioral health issues, generally on par with the way we think about the way we deal with other kinds of healthcare services. And I think, as many of you know, there's a tremendous amount of reporting in that bill, and also a big opportunity to measure and analyze behavioral health services. That burden will rest with GIA and with this commission, and I look forward to the annual reporting that comes out with regard to that. It also includes a range of other measures that are designed to bring mental health into the foreground and to dramatically improve its relationship to the healthcare system generally. I think this is something we have been working on, have a ton of momentum on, and we'll work very hard to continue to move forward on this between now and the time we leave office. I do think the front end on the mental health system can have a very positive impact on what I think of as the back end, the ER, the emergency, and all the rest. But it's going to require a lot of work. I think the resources actually are probably there financially. The biggest challenge is going to be staffing the organizations and the providers who will have the opportunity to play a much bigger role on the front end than we've been able to play historically. And I think finally, I would just say that we have a big opportunity to fully integrate the way we think about behavioral health and the rest of healthcare, which, frankly, has been a debate between and among a lot of the players in the system since I was in your job, Madam Secretary, many, many years ago. And I'm glad to see we finally got there on that one. We did achieve a very significant milestone on our waiver, which was approved several months ago. It was a very long and complicated discussion, and because we did bring some very new and unusual ideas to the table with respect to health equity, one of the cool things about being first is you're first. One of the not so cool things about being first is you are setting a precedent. And so there was a lot of, and I give the Biden people a lot of credit for this, there was a ton of back and forth between them and us over both what we were trying to do, and most importantly, how we were going to measure whether or not we were succeeding, and how they would measure whether or not, in fact, we were succeeding, given that it would require them to establish some new ways of actually monitoring and overseeing this waiver to do that. And the good news here is that eventually we came to terms on it and we got it done, and it was fully effective starting about a month ago. And it is $67 billion. It's a lot of money, no matter how you count it. And it will be effective from October of 22 through October of 20, through the end of 27, I think, 2027. Since one of the first things we did when we took office in 2015 was go chase a waiver, we are, I think, taking that particular burden off of the next administration. I do want to say one other thing about the waiver, which is it does continue to promote the accountable value-based care that was a big part of our last waiver. And there has been a significant amount of movement in that direction over the course of the past 8 years. I do think the big challenge at this point in time is pretty similar to the one that Deb talked about in her remarks, which is this whole issue of the relationship between price and utilization. The other thing you didn't mention, which I'm sure was embedded in there somewhere, is the whole question about place. Where you deliver the service is every bit as important as how often you do it and what the unit cost of it is. And I do think in the pandemic, because of some of the issues around staffing and because of just some of the changing nature and changing. When something lasts 2 years, a lot of habits get disrupted and new habits get developed. And I think one of the big challenges we have coming out of this is how do you get back to the idea that people start thinking about the community-based service opportunities first, and not the emergency room. I think that's going to be challenging just given some of the staffing issues and the changing nature of a lot of people's behavior. But I do think the waiver provides tremendous opportunities for everybody, and I look forward to seeing it implemented over the course of the next few years. I also just want to put in a good word for the Health Connector. It has been a terrific player on behalf of people who don't qualify for Medicaid for the better part of the past 8 years. At some point, the federal government will probably lift its emergency order, and Massachusetts will be required to redetermine for eligibility purposes the folks who are currently on Mass Health. The fact that we have a connector in place, it's well-funded, well-supported, and provides high-quality products to people who don't actually qualify for Medicaid under traditional circumstances is a really good thing, and makes us really, honestly, completely different than big chunks of the rest of the country. So I don't think for us, the change associated with that decision, which I expect will be made by the Fed sometime next year, will be as big a deal here as it will be in many other places. The one other thing I would just mention is I think the biggest challenge everybody's going to face going forward is we don't have a healthcare system that is in quite the same place operationally as it was before the pandemic. And that all by itself will create challenges for everybody who's part of the system going forward. And I won't necessarily be in the chair I'm in now. I'm obviously going to continue to be interested in this issue going forward. And if I can answer questions today or anytime between now or January 3rd or after that, I'm happy to be available to do so. And again, I appreciate the chance to testify. Thanks.
Thank you so much, Governor Baker. Thank you for being here in person, and thank you for your extraordinary leadership and service to the Commonwealth. Really appreciate it.
Thanks, Deb.
Do you have time for one or two
Yeah,
questions?
sure.
Any questions from commissioners for the governor?
Governor,
Hi, Chris.
thank you for that, for all those remarks. Going back 6 or 8 years, I think we talked about the problems with having a disease-based system and a transaction-based system, and instead now we're still hoping to move it to an outcomes-based system and serious value-based care. Could you offer thoughts of why you think it's been slow, what the impediments have been to change?
Well, what I said,
Despite all your wonderful efforts.
what I said when I was here, when I got asked a similar kind of question in 2018, is we don't have universal coverage in this country. We have it for the most part in Massachusetts, but we don't have it nationally. But we do have a single payer, and that single payer is Medicare. And Medicare pays on an RBRVS and a DRG, and everybody plays by those rules. And any attempt you make not to runs into some pretty serious headwinds. And it is the way people keep score. It's the way people have kept score since the 1960s. And you can do things around it, okay? You can do things on a demonstration basis, which we do a lot of here in Massachusetts. You can do things, and by the way, if you run a good demonstration, you can run it forever. I mean, I would argue to some extent the 1115 waiver is sort of like that, just on a much grander scale. But in the end, the provider community is going to calculate whatever it is you're doing, whether it's outcome-based, episode of care-based, whatever it is, they're going to ultimately calculate it against the Medicare fee-for-service average, RBRVS, and the DRG system. And honestly, given some of these issues about throughput that I was talking about previously, having a system that works like that is actually a big problem, because it doesn't necessarily reward you for being really good at the outcome piece or being really good at the step down and discharge piece. And experiments that have been pursued in this area have had a hard time gaining traction because of the difficulty associated with moving away from the system. I mean, there are limited demonstrations that started in 2016 and 17 where people literally said, here's the basket of services that we're going to incorporate into the way we treat heart attacks, the way we treat total knee replacements, the way we treat, a whole variety of particular services. And the theory was, if we treat this as one episode of care and then measure how we're doing in terms of delivering on that, we'll come up with a better process for doing that. And a bunch of places did this, and there are some demonstrations that are still going on. But in terms of getting people to just walk away from the underlying financial, transactional heartbeat that the system runs on at the federal level, it's been really hard. And that's why, our legislation basically turned that whole thing upside down, which freaked everybody out, which is part of the reason why I think it didn't happen. But I continue to believe that until somebody figures out how to make the front end and time-based care matter more than the technology in the back end, and can sell it, it's going to be really hard to get to where you want to go.
Great. Thank you so much, Governor.
Okay, folks. I look forward to your reports.
And now can I ask you, Vice Chair Cohen, to introduce our next speaker?
Thank you, Deb. It's my pleasure to introduce our next speaker, Senator Edward Markey. Senator Markey was first elected to the Senate in 2013, following 37 years in the U.S. House of Representatives. Throughout his career, Senator Markey has fought to guarantee quality, affordable health care for all Americans and has steadfastly expressed his belief that health care is a right, not a privilege. He has been a consistent advocate to protect and strengthen Medicare and Medicaid benefits, and has been a champion for federal investment in health technology and medical research, much of which is being done right here in Massachusetts. I am particularly grateful for his work to address the opioid epidemic, including his co-authorship of the 2016 provision in the law that expanded the availability of medication-assisted treatment by allowing physician assistants and nurse practitioners to prescribe these life-saving medications. It's my pleasure to welcome Senator Markey.
Thank you, very much, Vice Chair Cohen. Thank you for that wonderful introduction. Good afternoon, everyone. Thank you to the Health Policy Commission for having me here at your 2022 Healthcare Cost Trends hearing. Thank you, Chair DeVoe, and congratulations on your recent appointment as HPC Board Chair. With you at the helm, HPC's guiding mission of better health and better care at a lower cost for all residents is in great hands. Thank you to Governor Baker for his leadership on these issues, Attorney General Healey, Secretary Sutters, thank you for your great work. Thanks to our great legislators joining us here today, Senator Cindy Friedman, Representative John Lawn. I know Christine Barber is going to be here as well. Commissioner Berwick, it's good to see you, especially with the tables turned and you're asking the questions today. Thank you to the entire HPC board for your work to tackle some of the most challenging policy questions of our time. This is just an incredible moment. Across Massachusetts, there is collective anguish when the Patriots' playoff hopes dim, but we can always count on the HPC to deliver us the preeminent Super Bowl of healthcare policy. So you trade touchdowns, halftime shows, and guacamole for data points, pre-file testimony, and policy recommendations, which touch every family in our Commonwealth. And this week, the most important question is not Bailey Zappi or Mac Jones, but rather if the Commonwealth exceeded the healthcare cost growth benchmark. And on the greatest issue, we have the best workers in America as well, who do this all day long, every single day. Enormous debt to our doctors, nurses, social workers, all the healthcare staff who are at the heart of our world-class healthcare system. In the deepest depth of the COVID-19 pandemic, providers worked endless overtime, made heart-wrenching decisions about how to distribute ventilators. They fought for our lives, and as we confront mounting workforce challenges, we must pay back our debt by better supporting providers and workers. They were essential workers in order to protect everyone. And I'm honored to fight for investments to support our healthcare system, including through the 2020 Coronavirus Aid, Relief, and Economic Security Act, or the CARES Act, and the 2021 American Rescue Plan Act. As part of that, $115 billion in federal aid came to the state of Massachusetts, $115 billion. And the Commonwealth received, as part of that, billions of dollars to support our public health institutions, financially strained hospitals, home and community-based services, and nursing facilities. We made sure that the life raft was there for our community health centers. The funding was there for our medical institutions and for our families. It was absolutely critical that we had the funding that was provided. And the same thing is true. The government was just speaking about the waiver. That's another $67 billion. And as we know, a vision without funding is an hallucination. So the federal government has been providing this funding to Massachusetts in order to make sure that we use it well, but we use it innovatively as well, so that we create the models for the rest of the country. And that included $4.2 billion in relief payments for more than 1,100 Massachusetts healthcare providers, and those payments made the difference, closing revenue shortfalls in the midst of system disruptions and evolving demands for care. The bottom line is that the CARES Act and the ARPA bill delivered for Massachusetts and our healthcare system. But there is much more left to do here in Massachusetts. We can leverage where we are now to propel us to a healthier future. And most of all, we have to address the health inequities that the COVID-19 pandemic illuminated and exacerbated. Vice Chair Cohen, you talked about the opioid crisis. You talked about an issue that only grew worse through the COVID crisis, and we can see it, and we can see those who have been adversely affected by it. And we have to make sure that we focus upon that as an exacerbated problem. Dr. Martin Luther King Jr. said, of all the forms of inequality, injustice in healthcare is the most shocking and the most inhumane. In Massachusetts, COVID-19 claimed the lives of more than 20,000 people and sickened more than 2 million. COVID-19's toll has not been distributed equally. COVID-19 disproportionately affects communities of color, women, and disadvantaged communities who have long borne the worst healthcare burdens. A mere stone's throw away from where we're sitting, there is a reported 30-year life expectancy differential, 30 years, based on where you live. People in the Back Bay have a life expectancy of nearly 90 years of age, but in some parts of Roxbury, that number declines to 60 years of age. And we cannot blame the MBTA for that gap. What does cause that gap? Systemic discrimination and income inequality has robbed good health from vulnerable communities for decades. The pandemic shone a bright light on our fractured and fragmented public health system. In this hub of innovation, Massachusetts, we are the Bay State, but we are also the Brain State. And these solutions already are a way of life with a marriage of science, technology, and public health. Technology pioneers from the Commonwealth have developed wastewater surveillance that helped us to track COVID, the opioid epidemic, and monkeypox rates. Telemedicine is bringing health services to people all around town and to underserved communities across the Commonwealth and our country. And informatics and machine learning AI, 3D printing, and robotics are revolutionizing healthcare and helping to strengthen public health infrastructure and deliver effective healthcare. There is a revolution going on between technology and public health, and Massachusetts has a chance to be at the forefront of it. But it's marrying the MIT Media Lab with our public health infrastructure. It's understanding where that innovation is coming from and how it can be applied to public health. And this is cutting edge. Massachusetts has the institutions that can ensure we're in the lead for the whole planet. It's just a whole field that is forming right now, and we have all of the institutions that can make sure that we move forward with it. One good example here from a policy perspective is, yes, we have a mental health crisis amongst children. It has exacerbated dramatically. We had Frances Haugen testify before the Commerce Committee in Washington, a graduate of Olin University here in Massachusetts, an engineer. She just blew the whistle on Facebook in terms of the targeting of children, of young girls in our society, exacerbating already pre-existing issues they might have with their self-image. Bulimia, anorexia, ultimately ideation of suicidal tendencies. And Facebook was doing nothing about it. So here's a perfect example of where Massachusetts can pass an online privacy bill of rights for every child 16 and under. We see the problem. We know how that problem is being exacerbated. What's the link between technology and public health? And what's the recommendation that we can make in order to make sure that Massachusetts is at the cutting edge of protecting these children, giving parents the right to say to these marketers, no, stop targeting my daughter who's 14 because she went online to get information about bulimia and anorexia, because she hasn't. That problem is only being worsened. What rights should those people have in those homes to be able to protect themselves? We should be the leader here in Massachusetts. The prescription for what ails all of us is clear. We need to identify health inequities when and where they occur. We must elevate the voices of people who are most disadvantaged in our system and take bold and consistent action to provide a healthcare system that provides the world-class care in every home, birth center, community health center, and hospital to every person, no matter their age, their race, or their income. Diseases don't discriminate, and neither should we. Healthcare can only be accomplished through a health in all policies approach that involves providing education, employment, food security, transportation, and cultural opportunities, including community support. It means ensuring leadership roles for people of color and women in the health professions and in science. This is healthcare justice, and achieving it requires partnerships between all of us here today in the public and private sectors. Our goal, a healthier, more prosperous future for everyone. In 2020, healthcare spending dropped by 2.4% as people deferred care and skipped necessary appointments, yet premiums continued to rise. Behind every HPC data point is a family, a community, or a business forced to make impossible choices. They are the local mom and pop shop deciding whether they can afford to keep their doors open. They are the families sitting at the kitchen table working through their monthly bills and the mountaintops of paperwork, which are presenting themselves on a weekly basis. They're workers and seniors, immigrants choosing between paying medical debts or the rent, between filling prescriptions or the fridge, between getting a medical test or heating oil. Every impossible choice is a system failure. The HPC's data and research translates those stories into a collective call for action. And I'm committed to doing everything in my power to push for progressive health policy. Together, we will build a system in which the size of a person's paychecks doesn't determine their health. And that's why I'm so pleased to report that inside of the Inflation Reduction Act, which we just passed in August, there are big changes that have taken place. It's going to beat back rising drug costs by allowing the federal government to negotiate prices for top-selling Medicare drugs, and finally force drug companies to pay rebates if Medicare drug prices rise faster than inflation. The act also limits monthly insulin costs to $35 and caps out-of-pocket drug spending in Medicare Part D at $2,000 annually. And finally, the Act extends the expanded premium tax credits available for healthcare marketplace insurance purchases, which will provide savings for an estimated 212,000 Massachusetts residents, all in that one bill. The bottom line is this: the Inflation Reduction Act is keeping dollars in the pockets of Massachusetts individuals and families to simplify the choices that they have to make. We know that COVID-19 isn't the first pandemic, and it won't be the last. This pandemic provided us with a once-in-a-generation opportunity to rebuild our public health infrastructure, to relearn the lessons of the past, which we forgot, and to make sure that our health systems are there, but also guarantee equity and inclusion, which should always be at the heart of healthcare policy. And that's not a choice. We have to act, so we will be better prepared to weather future public health storms, including those caused by the climate crisis. This past summer, the Northern Hemisphere experienced severe droughts that dried rivers and crops. Among the hottest months, communities experienced extreme storms and weather events. Sea levels continue to rise off our coast. The planet is running a fever, and there are no emergency rooms for planets. We have to engage in preventative care. As climate change makes our planet sick, a sick planet erodes the health of its people. Hacking cough, global warming makes air pollution worse, harming our lungs. Sneezing and sniffling, climate change supercharges allergy season, and not just storms. Heat stroke, extreme heat is deadlier than any other extreme weather event. And infectious diseases, they're just going to continue to rise as every single year goes by. And it will come with a vengeance unless we prepare for it. So as David Wallace Wells has recently written, a single bat escaping a warm habitat might carry a novel virus hundreds of miles, perhaps from a cave in South Asia to the foothills of the Himalayas, infecting cattle or people and spreading exponentially from there. And many of these spillovers may have limited effects, but there will be thousands more of them, and not just from bats, because of climate change. COVID-19 has given us a sense of how disruptive just one global pandemic can be. But a new set of pandemics, plural, could deliver several at once, and we should begin to prepare for it, because climate change is setting up the conditions for that to happen around the planet. An ever warmer future will silently claim more lives than torrential storms and tornadoes. The climate crisis is not on our doorsteps. It is already in our homes. The compounding crises that are affecting our country today, mounting economic and social inequity, climate change, and racial injustice will require a bold, intersectional, and immediate response from our government. That is why Representative Alexandria Ocasio-Cortez and I reintroduced the Green New Deal resolution to confront all of these crises, these intersectional crises, and transform our economy and our democracy for all Americans. It's also why I reintroduced the Climate Change and Health Protection and Promotion Act. That bill mandates the development of a national strategy to identify, prepare for, and address the health impacts of climate change. And I'm pleased that the Biden administration listened to our call for this whole of government response by establishing the Office of Climate Change and Health Equity. I encourage the new office to coordinate with international, state, tribal, and local governments, and to come to Massachusetts to learn how all of these issues are interrelated. It will help support a health ecosystem that recognizes and can respond to the climate impacts on our health, especially in communities that often bear the brunt of climate injustice. The climate crisis poses a wave of threats to healthcare infrastructure and will bend the cost curve upwards, and we cannot afford to wait. Now is the time for us to deliver for our healthcare providers to ensure that they are not alone on the front lines of this crisis. Now is the time for Massachusetts and the United States to lead in bold, urgent action to ensure that we can deliver high quality, affordable healthcare to all people in the next generation and forever. Voting for the Affordable Care Act in 2010 is amongst the proudest votes of my 46 years in the United States Congress. And that's because I believe that healthcare is a right and not a privilege. As with all legislative movements, the path to that historic legislation was long and hard, but we persisted and we modeled it on Massachusetts. And that's what made all of the difference. We went first. We are the brain state, and we have to continue to look ahead and lead the way on all of these other technology-related, climate-related issues, and to do so now. To quote the legendary folk singer and social activist Pete Seeger, if someone says, I want to change the world, where do I go? And I answer, stay right where you are. Don't run away. Just dig in. So thank you to the HPC and all of the hearing participants for digging in today and every day. I am ready to continue to fight alongside you towards a more transparent, accessible, and equitable and innovative healthcare system. The National Football League may have invented the Super Bowl, but the HPC is working to perfect it. Thank you all so much.
Thank you so much, Senator Markey.
Thank you all so much.
Thank you for your support. Next, I'd like to introduce a video from our Attorney General, Maura Healey. Since Maura Healey first took office in 2015, she's prioritized efforts to tackle escalating healthcare costs. She's a strong advocate for Massachusetts consumers and understands the importance of community engagement to tackle these issues. The HPC has greatly appreciated a productive and collaborative relationship with her team over the last 7 years. And we want to thank Attorney General Healey for her leadership, her constant partnership, and for her participation at the cost trends hearing each year. Can we please play the video?
Thank you to Chair DeVoe for the invitation to be part of today's cost trends hearing, my last as Attorney General. And thank you to your colleagues on the Commission, as well as Executive Director Seltz and the HPC staff. I want to start by acknowledging the leadership of Dr. Stuart Altman, HPC's inaugural chair. We have all benefited from his wisdom and expertise, and I thank him for his service to the Commonwealth. I also want to congratulate the Health Policy Commission and all of its staff on 10 years of outstanding health policy analysis and insight. You've produced significant and high-quality health policy analyses and reports on a wide range of topics, from community hospitals to prescription drugs to telemedicine and payment policies. You've convened and presided over tough conversations about healthcare costs and the many other challenges our healthcare financing and delivery systems confront. You've accelerated the movement to value-based care through your standards for accountable care organizations and primary care coordination. And you've directly touched the lives of patients, from your Office of Patient Protection that safeguards the right to insurance coverage, to your investment in programs like the Beside Investment Program that improves care by increasing access to doulas. As we reflect on the achievements of the HPC over the past 10 years, this is also a time to consider what we'd like our healthcare system to look like going forward 10 years from now, and to consider what we need to do differently in order to get there. And Massachusetts has made great strides since the passage of Chapter 224. Ray Campbell and the team at SHEDA have provided us with sophisticated healthcare data resources needed for policy analysis and monitoring. Under Secretary Mary Lou Sudders, Mass Health has transformed its delivery system into a value-based model that centers health equity and investment in primary care. And the legislature continues to improve access to health care, fostering an expansion of telehealth and improvements to mental health services and coverage. These annual cost trends hearings have provided opportunities for my team to make contributions to our collective understanding of the healthcare marketplace. We all know that Massachusetts has the best healthcare providers and payers in the country, and probably the world. But our healthcare community is stretched. We're seeing extreme levels of stress and burnout. I know our doctors, nurses, CNAs, home health aides, community health workers, and more are exhausted. Unfortunately, many have left the caring profession altogether, and staffing problems have become a workforce crisis. Vacancies are going unfilled, and the dedicated professionals who remain are under even more stress. And we know that patients are also facing real challenges. People in behavioral health crises, including children, find themselves stranded in hospital emergency departments for days, weeks, or even months without access to the specialized care that they need. We're only beginning to see the effects of deferred care. Patients coming to doctors and hospitals with more advanced and more serious conditions that could have been addressed more effectively earlier, but for the pandemic. Families are struggling with monthly premium payments that have never been higher at a time when incomes are already stretched thin. And amidst all these challenges, the overriding concern facing all of us is health inequity. Inequity in distribution of resources and access, in underlying conditions that contribute to or rob a family of good health, and inequity in how people experience treatment in our healthcare system. I say all of this because we know what the healthcare system for the future needs to become. It will include a workforce that looks like the population it cares for. Needed healthcare will never be out of reach because of payment obligations, and premium costs will not threaten the economic vitality of our businesses. Care will be available in the lowest cost and in the closest setting possible, whether it's on the other end of a telemedicine screen or at a community health center. Our safety net hospitals will not wonder whether they will be able to stay open. Our premier academic medical centers will continue to lead the world with the level of care, research, and teaching they provide. In drawing from a report my office issued leading up to this hearing, we will find better ways to align health spending and resources with health need. But instead of looking at a health need as a reflection of past use of healthcare services, we can consider other indicators like social determinants and community conditions. Simply put, a more equitable distribution of healthcare resources is critical to containing costs while promoting access. We've made commendable progress over the past 10 years to increase access to care and to limit healthcare spending increases, but we still have further to go. With the talent and creativity at the HPC, in our healthcare and public policy community, and among all other stakeholders in Massachusetts, we will develop innovative ways to achieve these goals and to advance health equity for all. The HPC has advanced bold recommendations in its recent cost trends report, like setting new metrics and mechanisms for accountability and equity. Let's give those serious consideration as we embark on the next decade. I look forward to our shared work ahead. Thank you for all you do.
Terrific. We'll now turn to the next agenda item, which will be our keynote speaker and presentation. And I'd like to ask Commissioner Cutler to introduce that.
Thank you. It's my pleasure to introduce our keynote speaker for this afternoon. A wise man once noted that nobody knew healthcare could be so complicated. And we're delighted to. No, it was, I believe, the former guy is the official title of the person who noted that. And our guest today is someone who will make it be less complicated. So Barack Richman is a professor at Duke University, both in the law school and the School of Business Administration. So he has a good handle both of what the law says and what the economics say and where their limits are with respect to healthcare. He's done an enormous amount of work, including on contracting, on institutional economics, on antitrust, on healthcare policy. He has a degree in a legal degree as well as an MBA, one from an AB from Brown, JD from Harvard, and a PhD from UC Berkeley. And once he solves healthcare, which should not take that long, he, in fact, can continue our discussion because he represented NFL coaches in an amicus brief before the Supreme Court, and he was involved in Brady versus the National Football League, although he didn't say which side he's on. Just a little hint to you, in this area of the country, one side is preferred
I'm Brady.
to the other side. So in case you were wondering about which side you should be on. It's a great pleasure for me to introduce Brock. It's a pleasure for us to have him here. And I'm really, really looking forward to hearing what you have to say. So thank you very much.
Thanks very much, Professor Cutler. Thank you very much, Madam Chair, to the committee. It's an immense honor to be here. It's an immense honor to be able to share thoughts with you. Before I begin, I do want to express my admiration for Governor Baker and Senator Markey. I think both of them are remarkable leaders, and I think it says a lot about the Commonwealth that both have been elected for positions of leadership. My one complaint is that they both left without me getting their autograph. Maybe I'll circle back. Wanted to make sure the PowerPoint presentation is up. Click forward. There we go. Perfect. All right. So the title of my talk is Provider Consolidation and the Limits of Antitrust Law. As Professor Cutler mentioned, a lot of my research focuses not only on economic regulation, that is the effect of regulation, including antitrust, on markets, but also the operation of those legal procedures themselves. Not just looking at markets as through the lens of regulation, but also looking at the regulatory processes themselves and identifying potential within them and also shortcomings among them. So the title of my talk is Provider Consolidation and the Limits of Antitrust Law. And when I teach, when statutory interpretation comes up in my law classes, I often like to ask the question, what's the most important word in this sentence? And the hint I usually give is the shorter the word, the more important the word. So you want to look at statutes that contain the words or an, or shall. The most important word in my title is the word and. And in that particular reason, for the particular reason that the word and actually has a couple different interpretations here. So I will give a talk that has three parts. One, we'll talk about provider consolidation that is a result from the limits of antitrust law. I'll then talk about provider consolidation and its lessons from understanding the limits of antitrust law. And then I'll talk about challenges concerning provider consolidation given the limits of antitrust law. And to be especially bold, I'm actually going to try to talk about the limits of the law, not just the limits of antitrust law. So first, from the limits of antitrust law. There is a really interesting story that unfolded in the implementation of merger laws, of federal antitrust laws in hospital consolidation. I'm going to break this up in three parts. There was an enormous amount of consolidation that began in the early 90s. And the Federal Trade Commission, which is the agency that is mostly empowered to stop hospital mergers, brought a number of different challenges. These challenges involve a lot of dedicated resources, a lot of effort. And of course, when you bring a challenge in our American system, the agency confronts the parties before a federal judge in a federal court. And the FTC lost all 7 of these challenges. If we look back at what happened, there were a couple things that judges noted that suggested what the FTC did wrong. A lot of these are complicated cases, and the general principle, the general question, the legal principle involved is when there is a merger of 2 hospitals, we're asking the question, how much competition are we losing? And that is a function of how close the hospitals are to each other, or how much each hospital competes for a current pool of patients with each other. And most of these losses concerned technical matters. The FTC thought that there was a lot of existing competition between these hospitals. The defendants thought that there was very little competition that would be lost. The judges ultimately decided on fairly technical grounds that the defendants were correct. I do want to highlight one particular case, FTC versus Butterwealth. This was a case where the judge conceded, and the parties conceded, that there was a lot of overlapping competition between the two hospitals involved in the merger. But nonetheless, the merger was allowed to move forward because of pledges made by the hospitals themselves. The hospital said, we are nonprofit, therefore we are not profit seeking, therefore we will not raise prices. I heard a snicker behind me. I think that's probably deserved. But nonetheless, it illustrated another hurdle that the FTC had to overcome. So we had a string of challenges that were all that all resulted in losses. The Federal Trade Commission then looked retrospectively at a hospital merger and effectively was speaking to the courts and said, look, we will allow this merger to move forward, then we'll look backwards and see what happened to prices. And lo and behold, prices did go up. I call this proving the obvious. It was, you might say, a Pyrrhic victory. The FTC did not want to undo the merger. The FTC might have been looking forward towards more challenges. And ultimately, the FTC did start to effectively block maybe the most egregious mergers, but certainly some. So here we are, we have the narrative arc of antitrust law as it relates to hospital mergers. You might call it a success story. You might call it bad law being replaced by good law. The FTC finally getting it right. In large part, also, by the way, the FTC improved its techniques, how it proved that competition was being lost. And ultimately, courts bought the argument. Of course, it happened too late. This is data from 2009, by the way. And I know I don't need to offer all the evidence that provider consolidation, particularly provider monopolies, are a bad thing. Prices go up, often dramatically, quality goes down, access goes down, shenanigans go up. And we see from this history, I think, a fairly direct cause that provider consolidation was encouraged by the limits of antitrust law. Even though antitrust law got it right, ultimately, you do see a certain green light that many hospitals got during this period. This limit of antitrust law, I think, continues, and I think it also it continues to encourage provider consolidation. Right now, we see an enormous, actually I shouldn't say right now, over the last 10 years, we've seen an enormous spate of hospitals purchasing physician practices. This is certainly a form of provider consolidation. I think you've had witnesses before this panel indicating how much prices have gone up after these consolidations, increases in referrals, increases in low-value care. Antitrust law really isn't suited to stop these. It considers them vertical acquisitions. This is not, you and I both know that hospitals and doctors are alternative fora for delivering healthcare, and therefore are competitors. But that's not the way antitrust views them. Antitrust has been especially ineffective in stopping this kind of consolidation. There's been some really interesting research about the harms of what are called cross-market hospital mergers that, even though they are not in the same local market, nonetheless, once joined, might increase prices and reduce quality. This also, by definition, is not something that antitrust law can do, because antitrust is designed to look at competition within particular markets. Now, antitrust can do something about monopolists once they behave badly. And I don't want to be discouraging of this strategy. There have been a number of antitrust suits trying to stop monopolies, hospital monopolies, from foreclosing entry, from engaging in certain restrictive behavior that really does lead to any competitive consequences. But this is very hard, and this is very expensive. So what we see is not only a historic failure from a policy perspective of antitrust law to stop hospital consolidation. And by the way, that's kind of why we have the antitrust laws. We have the antitrust laws ostensibly to stop the formation of monopolies and to stop and to preserve competitive markets. But we have a pretty sharp policy failure over the last 25 years or so. And it continues to not serve the kinds of objectives that we would want it to serve. So, all right. So we're now going from consolidation from the limits of antitrust laws to what kind of lessons we can have looking back at the experience. And I think that one is some very significant institutional limitations of courts, of the law, of judges, and therefore of agencies. Courts are very mechanical. When there is an expert on one side, there's an expert on the other side. Cross-examinations always force questions about the efficacy or the persuasiveness of the evidence being presented to the court. It is very slow, and it doesn't always defer to authority the way, say, an economist might. You also see certain limitations in this history of the law. We have an adversarial process. We have a system that defers to generalist judges. The agencies, with all of their economic expertise, still have to convince someone who, is a constitutional scholar. And we not only see limitations to judges in that dispositional sense, they're not trained as economic regulators, but we also, I think this is especially evident in the Butterworth case, I think we see the introduction of ideology and bias. These are human institutions. These are not technocrats. These are not technically perfect institutions. And I think that it's really important to understand the failures of the antitrust laws and the operationalization of the antitrust laws as an opportunity to understand the limitations of the institutions themselves. So this is the most controversial thing I'll say, the logical leap. I don't think we're just talking about antitrust courts or the operationalization of antitrust law when we recognize there are very severe limitations to enacting policy. I'm relying on the old joke that economists often assume a can opener. How do you open a can? Well, let's assume they have a can opener and then everything works out perfectly. I think in some policy circles, and I don't mean to pin economists, I consider myself an economist, but in some policy circles, we sometimes assume a policy can opener. We sometimes assume that we identify bad behavior. All we really need to do is establish a rule that prohibits that behavior, and the behavior will stop, or at least the bad consequences that we're looking at will stop. I think what we see from this history of failed antitrust policy, the real difficulties of constraining the ill effects of the health system and the limitations of our public institutions. Another source of this worry that I have, or I don't know if the skepticism is the right word, but maybe wariness, is another recent line of research that I've been pulled into looking at the history of telecommunications regulation. There, of course, is a world of lots of price cap regulations. The Bell monopoly was subject to certain prices, and they figured out ways around it. You characterize certain costs as fixed costs instead of variable costs, and you can figure out, I'm sorry, the opposite. You fix certain fixed costs as variable costs, and you can increase the price that you charge. The other, I think, more significant shortcoming of telecom regulation is that the nature of the regulator and the regulated entity effectively is collusion against entry. And maybe that's somewhat appropriate when you talk about what could be a natural monopoly in telephony. But even in telephony, we saw real problems with restricting entry. In many ways, actually, the breakup of AT&T was successful only because it opened up technological innovation, not so much because it opened up competition. And I do worry that a path, well, any regulatory strategy in the healthcare sector, I think, has to encourage entry. Another source of worry about regulatory strategies to contain the ills of healthcare sector is actually what we've seen in the healthcare sector itself. If we pay by volume like Medicare does, we see McAllen, Texas, where there are excesses in volume. Where we pay by where we don't pay by volume, when we pay by price, then we see the grand junction taking place. It's a very, very interesting story that I'm sure you're aware of, where Atul Gawande wrote Cost Conundrum about the ills of McAllen, Texas, and how excess use of Medicare funds was deemed to be the source of problems. And in that article, there was great praise of Grand Junction, Colorado. And Zach Cooper, who I understand was a previous witness before this committee, wrote a paper about Grand Junction, about how precisely because it was not a volume operation, Grand Junction was home to monopolies. And what we see is the variation of provider strategy based on what kind of payment structure there is. When there is a Medicare program, we encourage McAllen, Texas. When there's private insurance, we encourage Grand Junction. We see the provider sector really adapting to whatever kind of regulatory environment that is built around them. I think we've also seen that with Medicare Advantage. When there was not risk adjustment, there was the recruiting of healthy patients. With the introduction of risk adjustment, there was the recruiting of, and I put it in quotes, the recruiting of sick patients. With a provider, and I think this is very much what the governor was saying in response to the question to Dr. Kreider. When the provider sector is very attuned to payment incentives, it makes it very adaptable, very capable of pursuing different strategies, different revenue strategies based on the regulatory and payment environment they're in. I think it's very hard to feel comfortable with a strategy that suggests that regulators can be one step ahead. I don't want to disparage the possibility of really effective regulatory strategies, but I do worry about relying on them excessively. So we're now in the last part of the talk. Given the limits of antitrust and given the limits of the law, what is there to be done? So this is my main argument. And in fact, actually, this is probably what I should have titled the talk. We need to change the political economy of healthcare. So what do I mean by that? Oh, by the way, I don't know how we spell healthcare. Here's an illustration of my state. And by the way, yeah, I do study the American healthcare system on a national basis. A lot of what I've seen in North Carolina, I think, has been especially illustrative of what happens nationwide. I think North Carolina and Massachusetts are two very different states. But towards the end of the talk, I will focus on some Massachusetts-specific suggestions. So this is a picture of Gene Woods, who is CEO of Atrium Health. At the time, it was Carolinas Health. That's the big hospital system in Charlotte, North Carolina. And that's Bill Roper on the left, who is at the time CEO of UNC Healthcare, which is a large hospital system based in Chapel Hill, but it's dominant in the center and northern part of the state. And this is a proposed merger. And the two of them are happy, and they issued nice press releases. And the reporting of the News of Observer says that the executives of the two companies said that the partnership would give them the leverage to negotiate better deals with insurance companies and vendors, saving the hospitals millions of dollars. Again, Snickers, perfect. Leverage over insurers doesn't translate into savings. It translates into higher prices. Okay, it might be good for the hospitals, but it certainly is not appropriate to describe it as savings, at least not in any economic sense. Now, this is a bad illustration for a couple of reasons. One is that this merger did not move forward. And another reason that it's a bad illustration is that this merger did not move forward, in part because of subsequent reporting by the News and Observer. There really was some very good coverage that identified the costs of consolidation. But that's the exception. That's not the rule. What typically happens among hospital mergers is you have the CEOs joining forces, issuing a press release, promising lots of efficiencies, lots of expansions of access, and then the story ends. There's no pushback. There's no pushback by the local community, by very little pushback by policymakers, and very little pushback by the media. This is the political economy of hospital consolidation, of provider consolidation, that we really need to confront. Again, one motivation is because of real worries of the limitations of regulatory responses. But even on a more fundamental level, if we're going to have a healthcare system that appreciates competition and that recognizes consolidation as a problem, we need to start addressing, let's call it the infrastructure of the political and economic system that would otherwise embrace competition. So here is a possible solution. It's another example in North Carolina. So North Carolina, like many other states, is exhibiting a lot of provider consolidation. We have about 5 large hospital systems, each of which has an urban epicenter, but is stretching throughout multiple rural parts of the state. And in particular, there is a hospital in Wilmington, North Carolina, which is in the easternmost part of the state. Wilmington is a coastal town. This was a county-run hospital, county-owned hospital, the only hospital really within a significant metropolitan area, so it had a monopoly. I guess that also means that there was no local competition. And the county wanted to sell it. And the basic question is, should Wilmington, should New Hanover Regional Medical Center become part of a larger hospital system? You had actually, I should, even before going to that slide, you had the executives of the hospital describing the merits of a possible sales. You had really all of those large hospital systems putting forward proposals. And ultimately, there was an agreement between the executives of this hospital and Novant. And then came Gene Merritt. Gene is a local businessman, and he formed a small coalition of local business leaders called Save Our Hospital. And really what Save Our Hospital is you can see that, nohospitalsale.com. This was an effort to mobilize the local business community to alert them to the large problems of hospital consolidation and of submitting their county to the dominance of a large hospital system. He got attention. He raised awareness and conversations were had that were never had before. The state's treasurer came not only to bring attention, but really to learn about the dynamics on the ground. Now, this also is a bad example because the sale still went forward. But this is the kind of thing that I think is necessary to change the political economy of hospital consolidation. We need voices from the main of the economy. Now, this is exactly what the HPC does. And in that sense, HPC really is a success story. I would say that if the HPC were in North Carolina, it's possible that the hospital, New Hanover Regional Medical Center, remains independent. And I really mean that. I think that with the kind of expertise that the HPC has, there would be significant attention by policymakers and local business leaders that would really raise questions that otherwise wouldn't have been raised and weren't raised. It's very few markets talk about healthcare prices and costs. And in that sense, the HPC brings them front and center in a way that very few organizations do. And I think that the Attorney General's report in 2010 and subsequent HPC reports really have transformed the way we talk about healthcare consolidation. And I think it actually has changed the way we study private healthcare financing. I think that Zach Cooper's research and the RAND reports are all products of the intellectual genesis that started here. I also think, and I could be wrong, but I also think that the kind of momentum that the HPC generated also had its impact felt in the litigation process when there was a challenge to partners acquiring South Shore Hospital and the Hallmark Health Hospitals. It wasn't just that there was data presented before the court that prices would go up with additional consolidation. I think also it was the momentum and the moral authority that the HPC had and the attention, the public attention that it brought, that significantly influenced the judge's decision. judges, courts, these are political entities. These are human entities. And having a very meaningful voice for data influences those outcomes. So my question, and this is what I'll talk about very briefly with the remainder of the talk, and I'd be delighted to continue a conversation either here or afterwards. Based on that core competitive advantage, the trust, the ability to gather data, and the regard to disseminate data in a trustworthy way, how might that be leveraged additionally in a world where political and regulatory interventions do not guarantee success? So I have 4 areas. One is how leveraging information might influence buyers. Another is how it might influence reporters. A third is possible new reports. What kinds of additional information might encourage different kinds of market behavior. And the fourth is, broadly speaking, local collaborations. So regarding buyers, it's very useful to recognize that most healthcare purchasers are large employers. And the Pacific Business Group on Health, actually now it's called the Purchaser Business Group on Health, has cornered the market, you might say, or hopefully not cornered the market, has been an instrumental leader in showing how large purchasers, large employers, really can move the market and can demand greater efficiencies in healthcare markets, and also specifically navigating the problems of monopolies. So what if we were to implement those plans here, you might consider, in addition to providers and payers testifying before this commission, perhaps encourage buyers, large employers to testify before this commission. Now, in looking at the largest employers in Massachusetts, the political economy doesn't really lend itself into a natural solution. But we do see a lot of retail. We see the University of Massachusetts. And by the way, if I were just to go back 2 years ago to 2020, we see Harvard University there. When I saw Harvard University up there, I was reminded of when I was a student there, and we had our child, and we were on the Harvard University plan. And nobody told us that Mount Auburn Hospital was a great place to deliver children. We went to Brigham and Women's, and we had no financial consequence to going across the river. The only consequence was me making sure that I knew how to drive there across the river in January. I practiced. But I can imagine the head of benefits coming before this committee and being asked the question, so why don't you have a narrow network? I'd be very curious to hear what the answers are. When you talk to large employers, I'm sure many of you have, I'm sure you talk to them all the time. Some of you are large employers. There's a perception that a comprehensive network is really necessary to make any kind of insurance product viable for your employees. The employees really demand full access. First of all, there's a lot of research to suggest that's not true. That's not true. That in fact, actually, most employees, not just income-sensitive employees, but most employees really would prefer lower premiums in exchange for a narrow network. But there is something that is somewhat curious about how unresponsive a lot of large employers are in seeking out economies, in trying to use their purchasing power in ways that would benefit their employees and ultimately the market itself. I was looking at the Department of Economic Research for other large employees. Again, it is important to note that a lot of the largest employers aren't beneficiaries of high healthcare costs, but there are some that aren't. We see Staples and TIAA. So if we were to pull a Gene Merritt here, we would think about all the parties who are generally silent on hospital mergers and other issues of healthcare policy, and think about mobilizing some kind of awareness and some kind of political demand, or maybe even market demand, for a more cost-conscious way of purchasing healthcare. Another example, and this I think is much more relevant in North Carolina than it is here in Boston, where the Boston Globe has really done some very, very impressive investigative journalism projects into the cost of healthcare. But I mentioned that in general, you have a hospital merger that's announced, and the local media republishes the press release. And this is especially true in North Carolina, where local journalism, other than in the two largest metropolitan areas, really is very weak. I often talk to the local healthcare reporter. Actually, I only talk to some local healthcare reporters because only some have the incentive or the appetite to call me. Because most of them are also the agriculture reporter and the environmental reporter and the crime reporter. So one thing that some organizations have done has invested in making sure that we have a more informed media, that healthcare journalists understand healthcare markets and healthcare economics. And we're trying to do that at Duke as well, again, focusing on North Carolina. This might be a really significant advance in changing local narratives and changing the political economy, the local political economy of healthcare. I don't know, but we're trying. Another possibility that the HPC might consider is not just thinking about publicizing prices locally, but maybe publicizing prices, well, the opposite of locally. It is useful to know how much knee replacements cost at different places in Massachusetts, but it would be really interesting to find out how much it would cost in New Hampshire or North Carolina, or maybe even the Cayman Islands. There are lots of untapped sources of competition. One reason I think antitrust law as an enforcement mechanism has been ineffective is because it's very hard to define the market. What are the contours within which competition actually takes place? I think the truth is that competition can take place in broader arenas that we consider. And that might be something that the HPC could facilitate, or at least inform a public about the possibilities of seeking care elsewhere, and perhaps even assessing quality as well. This did happen in North Carolina. Lowe's is headquartered in Charlotte, and it contracted with the Cleveland Clinic to send all of their employees for certain procedures to Cleveland. And they did it at a price that avoided the local monopoly price. And of course, the Cleveland Clinic comes with a great record of high quality. I don't know how many patients went. I think very few employees went. But of course, once the possibility emerged, the local providers reduced their prices. Expanding the possibility of competition doesn't just mean that there are cost savings elsewhere, it also can mean that there are cost savings locally. And the fourth possibility that the HPC might consider is utilizing its unique position as a local authority. And that might be especially useful for another research project that I just recently completed on looking at administrative costs in healthcare. This just came out in Health Affairs, where effectively we look at representative institutions in different countries, and we ask the very basic question, how much does a provider pay to get paid? We often call it, how much does this bill cost, was one of the subtitles. How much does a bill cost? Like, how much does it cost for me to collect on this bill? It's only insurance and billing related prices. And we win again. The United States exhibits much higher administrative costs than other countries that we looked at. And of particular note, I'll point the contrast between the US and Germany and the Netherlands. In Germany and the Netherlands, you have a system of private insurance. It is a relatively competitive market. And we think there are some fairly specific and identifiable reasons why administrative costs are so much lower there. And it's all mechanical. So if we were to think about how to incorporate the lessons from that study, we identified a number of different costs that came from the complexity and the duplicity of, or duplication, I should say duplicity, although there probably was some duplicity involved also, of contracts between providers and payers. Providers are given a number of different contracts by different payers. They're all very unique. They're all very complicated. They're all very detailed. And look, this is where a lawyer can actually help the healthcare sector. We know about administrative costs. We know about what happens when there are lots of different contracts that are more or less trying to administer the same transaction. And there have been lots of instances where lawyers and industries have come together to standardize contracts. And that's the kind of thing that local leaders could do. Imagine collaborating with the Department of Insurance to say, look, we're going to come up with some kind of standard template for contracts between payers and providers. I'll say the obvious. Often when you're talking about a price, you're also talking about a wage, but reducing administrative costs is a win-win. It really is something that everybody could agree to, I would suggest, but it's also something that collaboration in a local market really can address. Relatedly, and this is speculating a little bit, there also might be something that could be done locally about developing an electronic health record system. Electronic health records is the siloing of data. We don't have a whole lot of competition in the EHR market. A lot of both EHR vendors and providers use the siloing of data to exercise their market power. Many physicians, for example, acceded to being purchased by hospital systems only because they needed access to their patients' data. But what if we were to free up the EHR system? In the early aughts, I would tell my health law students, did you know you could buy insurance on the internet? And I would show them the Mass Health Connector website. And it was revolutionary. The whole idea that you don't have to go through brokers or large employers to do that. And this URL is something that I've made up. I don't know if it really exists. But imagine the state doing something about EHRs, where everybody can upload and download their EHR records. Any patient can go to any provider. You have certain security, the two-factor security that would make it happen. It not only would free up, remove the siloing of data, but it might also really facilitate administrative costs as well. Because of course, much of the administrative costs come from the certain architecture that the EHR systems are imposing. And again, the emphasis idea of the opportunity, or I guess the value added of having an HPC would be looking at local solutions and solutions of collective agreement. So the main argument, we need to change the political economy of healthcare. And if we do, then policy corrections become easier or at least less urgent. And I just want to highlight what I mean by that. If we change the political economy of things, we can improve the markets and therefore maybe not being as great a need of policy solutions, but we also can improve the efficacy and facility of policy solutions too. And that's true for whether we're pursuing a lawsuit in courts or having an administrator issue some kind of regulation or working with the legislature to come up with collective solutions. I'll say again, it's been an enormous honor to share these thoughts with you. I don't know if we're over scheduled, but I'm delighted to answer questions. I'm also delighted to continue the conversation elsewhere too.
Thank you so much, Dr. Richman. Thank you. Really appreciate your thoughts for our future, and we would like to continue the dialogue, but due to time, we'll do that with you separately. Thanks so much. We want to move to one other agenda item before we take a break, and that is to have a two-part presentation from the Health Policy Commission team. First, my pleasure to introduce Dr. David Auerbach, who's our Senior Director for Research and Cost Trends, and he's going to bring our discussion back to Massachusetts and provide us with the data and facts on healthcare spending in our state and the impact of that on affordability and equity, and then to turn to our Executive Director, who will provide a short presentation on proposed policy solutions. So Dr. Auerbach.
Okay, great. Thank you very much. I am also so glad to be here in person, and thank you, commissioners. And I also want to thank my team and everyone else at HPC for helping put together it's an enormous amount of data here, and I'll try to get through it without taking too much time. This really is going to be touching on a lot of the same themes that have already come up today, and hopefully providing a database behind some of those trends. So it's going to be in 3 broad sections. First, I'll describe what we know about the current healthcare landscape today, separated into trends in utilization and workforce, and then prices and spending. Then I'll step back a little bit and talk about some of the broader trends we've seen in the last 10 years at the HPC, and then talk about implications for affordability, access, and equity. Okay, so starting with utilization and workforce trends. And I apologize, it's a little bit hospital heavy. That's where we have the most recent data. And I appreciate the work the hospitals and CHIA does to get us that data very soon. But I will also talk about the other sectors as recent as we know. So starting with trends in the total number of hospital discharges or admissions, either way. This is showing the trend from the beginning of 2019 until today. And the top line shows the total number of discharges. It is still a little bit below where we were before the pandemic. It's about an 8% drop in total. And it's important to note that that drop is different based on the type of hospital admission. It's about twice that, about a 17% reduction in scheduled admissions. And an important example of a scheduled admission, one of the higher volume of such admissions is hip and knee replacements. These make up a pretty high proportion of scheduled admissions, and they tend to be a high margin admission. And these have dropped since the pandemic began and have not recovered at all. It's about 45% down compared to where they were before the pandemic. Some of the hip replacements we did see in 2020 shifting to outpatient sites. We did not see that in the case of knee surgeries. We can look at hospital volume by type of hospital, by category, and we see by far, well, except for the specialty hospitals, which are relatively low volume, the biggest drop is in the high public payer community hospitals, a 14% reduction in volume. So that suggests that there is a shifting going on of patients from those hospitals to the other types of hospitals. We wanted to understand trends in patient acuity, level of sickness, and this could have implications for costs as well. And when we compared trends before and since the pandemic, we don't really see a change in the trend. The top line is showing patient acuity as measured by the case mix index, which is a common measure. This is the basis really that hospitals are paid on. And even though it is higher since the pandemic than before, that's a continuation really of a trend that has begun a long time ago that we've showed, mainly due to coding and not due to sicker patients. So that trend has continued about at the same rate. And on the bottom, another measure of acuity is how much time patients spend in the ICU. And that measure of acuity has been steadily dropping over time, and it has continued to drop at about the same rate as it was before the pandemic. Now, one measure that has increased, as we know, is length of stay. And when we look at length of stay, you see an interesting pattern, though it's not for all hospital admissions or discharges. It's really just for those that are ultimately discharged to home health care or to skilled nursing facility sites. And this is really pointing back to some of the staffing and other bottlenecks related to discharging those patients from the hospital. We don't see an increase in length of stay for those that are discharged to home. And so while the total number of hospital discharges has dropped, when you combine it with that increase in length of stay for some, you get a picture of the total number of people in the hospital at any given time is roughly constant. And that's what this graph is showing. So the hospitals are as full as they were before. And add that to the fact that some beds are not able to be staffed, some capacity has gone offline, and the occupancy rate is actually even higher. So there's a bunch of things going on that combine to make this complicated phenomenon. Okay, now turning to emergency department volume. Here on the top line, we see that bigger drop early in the pandemic that we've shown before. And by today, the total ED volume is just about back to where it was before the pandemic. But we still continue to see a sustained drop in the avoidable ED visits. That's the green line, about 14% below they were before the pandemic. The other phenomenon that we've talked about a lot in the ED is the boarding of behavioral health, mental health patients. This is the percentage of patients who are in the ED for a mental health or SUD condition that stay there for more than 12 hours, often waiting to be discharged. And that boarding rate for mental health patients is now up to 50% by June of 2022. It really has increased from 38%. Okay, moving to outside of the hospital a bit, we've talked about telehealth, really a game-changing phenomenon that has happened, and it's quite amazing that this is showing the percentage of all visits that are delivered by telehealth. The mental health are in the blue, 80%, even through 2020, and this, from what we understand, pretty much continues today. 80% of mental health visits are telehealth visits, and even outside of that, all the other visits combined, it was about 16% by the end of 2020, and that is still, we believe, somewhere in that vicinity. It was almost nothing before the pandemic. So that's a persistent trend and a very helpful trend. As Governor Baker noted, the no-show rate is much lower, and these really increase access. And as an example of that increased access, we saw in 2020, really aside from drugs, the one category of care that did not drop in utilization was mental health visits. And here, separated by age group, especially for the young adults, you see those visits increased in April through June of 2020, and throughout 2020 continued to increase, which is great in terms of it's probably showing better access, but also probably not great if there were increased mental health needs during the pandemic, which there probably were. And finally, turning to some of the workforce issues that are so challenging and pervasive throughout everything else that we're talking about. This one is showing employment, including contract labor, so really the total workforce size by healthcare sector. And I'm showing changes from 2019 to 2020, 21, and the first quarter of 22 here. And you see I'm highlighting 3 of those towards the end, where total employment has dropped considerably in the home health sector, in psych and SUD hospitals, and in nursing facilities. About 24% fewer people working in nursing care facilities than before the pandemic. And that really, as we have shown, leads to bottlenecks and disruptions throughout the whole system. And you see at the same time where there were drops in employment, rises in wages, really indicating a shortage. You see wage increases combined over the 3 years of 36% in psych and SUD hospitals, 25% in nursing care facilities, and so on. So really, they're having to pay more to try to fill these slots, and they're still not filled.
That includes contract labor.
Yes, and again, that includes contract labor. Okay, so now the next section, continuing the current landscape, I'll talk about spending trends and then prices. The spending trends, and this is just through 2020, but for the commercial data, as we've seen, our commercial spending growth was above the US average for the first part of the 2000s. And we then came below in 2013, and we've been below since, but that gap you can see has closed, and our spending growth reduction compared to the US, we finally closed that gap, and we pretty much are in the same place at this point. Here is a trend, including data into 2021, where in the pre-filed testimony provided by one of the larger insurers, you can see they are contrasting their own trend in terms of unit cost, which is like prices, that's in the orange. That has been increasing more and more each year, and their trend in utilization, and you see the big drop in 2020, and then the bounce back in 2021. And so combining those two, 2021 is looking like probably a double-digit growth year in terms of total spending that we will probably see when SHIA releases the data. And again, this also furthers the note that we've talked about where unit cost prices are the bigger driver of spending than utilization. This is showing data for Medicare that we do have for the full 2021, the same kind of pattern where spending was down in 2020, it's divided by category of care, came back in 2021, and in the hospital sector, really not that much of an increase taking the 2 years together, just about 0.7%. A bigger bounce back in professional spending, and prescription drug spending grew a pretty fast clip in both years. And so that was really driving that 10% increase in spending in 2021 for Medicare. And going back to the theme of so now we'll talk about some price trends throughout what we know through 2020. Prescription drugs, we have noted a fast increase. The average gross spending per branded prescription was $900 in 2020 in Massachusetts. That's an 11% increase from the previous year. And about 50% increases in out-of-pocket spending for a number of common drug categories from 2017 to 20. We saw price increases in the inpatient sector and the hospital outpatient sector around 4%, less so in the physician office sector. And drilling down a little bit onto the hospital inpatient side, another prominent feature of the landscape that we talk about is price variation. This is average commercial payments for hip and knee surgeries across hospitals. The commercial payments are in the blue. The Medicare payments for those same exact surgeries are in the yellow. You see the blue lines are always higher than the yellow by quite a bit. And you can see about 2-to-1 variation from between $40,000 and $20,000, depending on what hospital you have this operation at. We also look at price variation in the hospital outpatient department. Here it's even greater. This is an example of just common lab tests, where we created an index of the 50 most common and priced those out at every hospital or office setting or even independent labs in the state. And you see in that gray hash, that's what Medicare would pay, about $3,800 for this same basket of lab tests. And you see if you get those tests at a hospital outpatient department, that collection of tests, you run up to $12,000, $13,000, $15,000, even $20,000 for the same tests. And the cost sharing, the amount the patient pays, is that sort of light shade at the bottom of each bar. That is roughly proportional. So you are paying more as the patient too, based on where you have these tests, and they're the same tests. When we take all hospital outpatient services together, we also constructed an index there. And this graph is just showing how that varies by hospital system and how the levels on the x-axis and growth on the y-axis. And that trend upward to the right is showing that variation is increasing. The higher prices also have the higher growth on average. Okay, so that's the first section. I won't read through these bullets, but that's kind of giving a sense of where we are today. Okay, now I want to go back and look at some of the long-term trends, and we've talked about many of these. The trend in consolidation that Dr. Richman talked about. Here we're showing from 2010 to 2020, what proportion of all hospital care took place in the 5 largest hospital systems, and you can see that that grew from about 45% in 2010 to over 60% in 2020, and it might even be a little bit higher today. At the same time, the percent provided in independent community hospitals is shown by that gray line that has dropped considerably. Some additional consolidation trends, some of these have been, talked about. More and more hospital outpatient visits are taking place at high-priced hospitals between 2016 and 20. We see a shift in maternity care away from community hospitals towards academic medical centers. We see more physicians employed by hospitals. This data point is for the whole Northeast region, but it's dramatic, from between 22 to now 49% of physicians employed by hospitals in the Northeast. And when we look at hospital services that have closed, it's mostly from the hospitals with low prices, with high public payer mix in the more rural areas of the state. And a lot of those closures are pediatric and maternity services. Okay, some other long-term trends. We see a long-term trend in commercial spending per hospital stay. We've shown this before. It's a growth of about 48% from 2013 to 2020. And you can look at that growth compared to other indices. For example, inflation grew only 13% during that period of time. CMS's hospital input cost factor grew 16%. And even if you consider all payers, including Mass Health and Medicare, that's about a 28% increase in hospital payments per discharge. Now, of course, inflation has increased recently, and I don't have the other spending data for 2021 and 22. This trend in coding we have documented. I talked about it earlier. This is coding on the inpatient side, and we just see a trend towards patients being coded into higher and higher acuity levels and higher payments resulting from that. And we also see it in the risk scores. which, as Dr. Richman noted, Medicare Advantage pays based on risk scores, and they are also a factor in payment in APMs. And we see the same drift. We see the same drift in risk scores. It's not that the population is getting sicker. So there are also important trends in prescription drugs. Growing spending, a growing portion of the total commercial pie from 14.5% to 18.6%. We see a lot of the spending is especially in a small number of high-cost products. These specialty drugs are now half of national drug spending in 2021. We see a huge rise in launch prices. In 2008, the median launch price was $2,000. Now it's $180,000. And these price increases have just increased at a very high rate, much faster than inflation, as the CBO notes here.
And the number of drugs that were approved have doubled in that same time period.
That's good to know. Yep. So more drugs, higher prices. Yep. Here, moving back to some of the demand side incentives that we've talked about before. Limited network plans account for still a very small share of plans in Massachusetts. A lot of those are in the GIC. They have not taken hold. Tiered network plans are a little bit higher. That proportion grew from 2013 to 15. It hasn't grown anymore. And again, a lot of that is in the GIC. It would be about 14% without the GIC. And as we know, what has grown is high deductible plans from about 15% to 38% by 2020. And without the GIC, that's about 42. And if you look at small group plans, it's more than 2/3 are high deductible plans. That means you have a deductible of over $1,400 for a single person or $2,800 for a family. We can look at APMs, another one of the strategies that we've been hoping would transform care. They have grown somewhat in a proportion of original Medicare with the Medicare ACO programs. In Mass Health, of course, they have had a huge increase lately with the ACO programs there. But in the commercial market, APMs they increased to about 40%, and they have not grown since 2016. And a summary of these findings. Okay, I'll move to the third section. So some implications of this for affordability, access, and equity. I've shown this before, but I love the animation. This is the increase in the average cost for a new compact car from 2000 to 2021. It ticked up a bit in 2021, of course, with inflation. And here's Massachusetts' average family health insurance premiums. It used to be 1/3 the cost of a car, and now it's the same. And this is not including auto. Bring that up to about $25,000 per year per family, more than $2,000 a month if you included that. We see high rate increases in the merged market lately, in addition to the employer premiums I showed a minute ago, about 7% per year for the last 3 years. And what do people do when they face those high rate increases? One of the obvious ways is to increase the deductibles, to try to reduce that premium growth. And when you increase your deductibles, you have a lot of people going without care. And this graph is showing people in high deductible plans are twice as likely to avoid care that they need because of cost. They're facing that deductible, and it's even higher for people of color. This is showing that when you divide up commercial residents in the state by the decile of the income in their zip code, the people in the lowest income zip code, 15% of them used no care in 2018 and in 2020, avoided all care entirely. I mean, some folks were healthy, but that decile is not healthier than the top decile. Avoidance of care. Also, it varies by income, of course, as I showed. People with ESI and income below 400% of the poverty level are twice as likely to avoid care, to report that they went out without care because of cost. It's higher for people of color, and it's even higher for people with activity limitations, as you see on the right. And just bringing this back to affordability in general, a 2021 survey found that 3 in 4 Mass residents are worried about affording healthcare in the future. And part of what they are thinking about is if we construct typical expenses or a budget for a household in the Boston metro area, looking at average spending for a family of 4, including transportation, childcare, food, housing, when you add the healthcare on top, expected typical expenses are more than your income. It's a serious affordability challenge, and people find that they have to cut back on those basic expenses just to make ends meet. And you're a little bit better off in the Worcester metro area, but not that much. With that depressing note, I'll turn it over to David Seltz. I think we decided we didn't have time for questions, but if there are any quick ones, perhaps we could do one or two.
Yeah. Any questions from commissioners for Dr. Auerbach before we move to? Yes.
David, that launch price data is it for like a year's supply of a drug, or how we interpret the $100,000 launch?
Yes, I believe it's a year's supply of a drug. Yes, and that's nationally.
Per utilizer, per annual.
Per year,
Per year.
per annum?
Dr. Carter?
David, you covered branded increase. What about generics?
I don't have that data, but we did show in an earlier presentation the branded share of drug spending in Massachusetts has grown. So, but the generic, is there an increase in the generic prices? Probably, but I don't have that at my fingertips.
Thank you. Thank you. It's really helpful to have this common fact set, particularly as we move into the panel discussions this afternoon. Thank you. Director Seltz?
Thank you, commissioners. And so given the reflection on these data points, and as Dr. Auerbach reflected, we have 10 years of data on some of these trends. And so how does that inform our policy strategy moving forward? How do we evolve and enhance the tools that the Commonwealth puts in place in order to be able to promote affordability and to moderate healthcare spending moving forward? And so this year, the Health Policy Commission advanced a comprehensive set of recommendations in our cost trends report to do that, to chart a new path forward for the next 10 years, reflecting on the challenges of the current environment and reflecting on the data and evidence. Also reflecting on where other states have been innovators and leaders in implementing new strategies. In particular, of the 6 recommendations, we urged for action in 3 specific areas. One is around enhancing our ability to target above benchmark spending growth, that we should learn from our experience in implementing the performance improvement plan process over this 6 years to be able to evolve that process and use different types of metrics to understand which organizations are contributing to excessive spending growth, as well as to be able to understand the variation in the position of different organizations based on their price levels, their market size, and the populations that they serve. As noted, the price impact, the price is a driver of healthcare spending. And so we recommended that the Commonwealth should consider placing limits on price growth and placing caps on the highest price pricing in those places where the market is failing to constrain either price growth or price levels. We see that this price phenomenon is not just on healthcare providers, but also on the pharmaceutical space as well. And finally, we need to ensure as we create savings in our healthcare system that those savings are truly passed along to consumers and businesses that bear the cost of our healthcare system. And so we recommended enhancements to the Division of Insurance review process and to incorporate standards of affordability into that process to ensure that as savings are developed on the provider or pharmaceutical side, that truly the consumers and residents of the Commonwealth benefit. These were areas that we really wanted to highlight for urgent action, but they don't encompass all of the recommendations that we put forward in this report. And so I just want to highlight a few other important aspects here. I've already touched around the opportunity to strengthen accountability for the healthcare cost growth benchmark, including on reevaluating the metrics, as well as potentially considering greater enforcement tools and financial penalties. I mentioned constraining excessive provider pricing, but also see opportunities to limit facility fees in places where those additional costs are not appropriate for the services that are being provided. We think there's opportunities to enhance scrutiny of different types of provider activity beyond just consolidations and including expansions, and adopting an out-of-network default payment rate. On the pharmaceutical space, we see a great opportunity to enhance transparency, not just on manufacturers, but on pharmacy benefit managers, and to expand the very successful program that has been in place at MassHealth to evaluate the pricing of drugs in relationship to their value. And in so doing, we can create savings that would limit the out-of-pocket exposures for patients who have to pay for these drugs to treat their chronic illnesses. I've already mentioned making health plans more accountable to ensure that those savings are passed on. Some additional sub-recommendations to highlight here, though, are reducing administrative complexity. Professor Richman talked about this opportunity for a local collaboration and a local ability, a collective action to say, how can we identify areas of administrative costs that do not provide value to patients, to providers, to the delivery of care. A few years ago, we estimated that administrative costs that don't provide value could exceed $1.5 billion for our healthcare providers. If we can create some savings for our healthcare providers in this environment, that is, as Professor Richman said, a potential win-win. I also want to mention here the continued push for alternative payment methods. David Auerbach just mentioned the stagnation of the adoption of APMs, especially in the commercial market. And we have a perfect counterpoint to that in the Medicaid program, where there is now almost universal adoption and a shift to value-based payment. What can we do to advance that in the commercial space as well? Throughout all of this, we see abilities to incorporate concepts of health equity into everything we do in healthcare. In particular, I want to highlight, again, the ability for payer and provider contracts to advance health equity. Again, MassHealth is perhaps a leader in this area. And finally, another of other areas that we think can improve the value of care in the Commonwealth by focusing investments on primary care and behavioral health care. And within the benchmark, actually increasing the proportion of dollars that we put into those services, understanding that healthcare systems that invest in primary care and behavioral health care are much higher performing. These are recommendations that we have put forward. We look forward to working with the administration and the legislature. I would note and highlight that many of these recommendations were included in pieces of legislation proposed last year by both the House and the Senate and the governor. And we look forward to advancing these next year. And we are not alone in innovating in this space. There are now 7 other states that have adopted healthcare cost growth benchmarks, and they are evolving their approaches. For example, Rhode Island and Delaware are both implementing hospital price growth caps. Rhode Island has been at this for a longer time, and there's actually tremendous evidence that the implementation of hospital price growth caps did not have a negative impact on quality or access to care. Delaware is implementing a program now. We also have seen states move forward on greater accountability underneath the benchmark. Both Washington and California are including the concept of greater financial penalties for organizations that exceed their health growth targets. And then finally, states are really leading the way on pharmaceutical transparency. Washington and Oregon have put in place very robust systems for being able to truly understand the price growth and the value of different pharmaceutical, different drugs, recognizing that that's a growing part of the healthcare dollar. So we look forward to engaging in this conversation with all stakeholders, but more importantly, we look forward to engaging in a conversation with our next 2 panels about what are the potential policy solutions that we should be pursuing together. Thank you.
Thank you so much, Director Seltz. We're going to take one question from Commissioner Cutler.
I had a question. I think that went back a little bit to David's presentation, but Ray may be in a good position to answer as well, which is we've heard a couple of things today. One is we've heard that prices keep going up, and that was David's presentation showed some of that. And then we've also heard that costs, particularly for labor, keep going up with labor shortages and so on. And I guess I'm wondering, do we know what's happening to margins? So that, do we know, like, is there room to cut prices? Is there room to cut prices at some places and not others? Like, what do we know about the current state of the margins?
I mean, CHIA does track the margins of the hospitals and health systems in Massachusetts on a quarterly basis, so we do have that data, and you did see a significant deterioration of margins during the 2020 and 2021, offset, however, by federal and state financial assistance. So it's a complicated picture. What'll happen when that assistance is no longer available is a different question, but CHIA does track revenue, expenses, and margins at healthcare institutions.
So at the moment, there's capacity to cut prices because the margins are not razor thin?
I would be reluctant to ad lib on that. I think we could provide data to the HPC, our most recent analysis of margins in the system, but I wouldn't want to speculate, at least without talking to my team.
You can follow up on that. And what is the most recent data that's available?
It would be for the quarter ending in June of 2022, and very soon we'll have data through October of 2022 published.
And that is important data because we'll see the full fiscal year picture for hospitals in particular.
The only thing I would add is what Ray said, is we need to disaggregate the temporary increases from the margins, because if the temporary, like the 10% bumps we didn't like, if those aren't continued on a more permanent basis, then it's, one time.
Yep.
Good.
Thank you, commissioners.
Thank you. We're now going to take a brief break for about 10 minutes before we reconvene for our first panel. So we'll see you all back in about 10 minutes at around 2:25.
All right.
First, Michael Curry, who's the president and CEO of the Massachusetts League of Community Health Centers. Bill Grant, who's the chief financial officer and senior vice president at Cummins Properties. Welcome. Colin Killick, who's the executive director of the Disability Policy Consortium, and Amy Rosenthal, the executive director of Healthcare for All. I'd like to start our discussion by asking each panelist to respond to the same question, which is, what impact do you see from increasing healthcare costs on consumer and patients? Could I turn to you first, Michael, to respond?
Thank you, Deb. First and foremost, just an honor to be here today and representing community health centers. And your inaugural cost trends hearings, Deb, since I've known you most of my professional career. So just an honor to be here and with you. It's so interesting as I was listening to testimony today, and what struck me is I thought Massachusetts is a special place as I was listening to the governor. When I travel the country and I get to talk to folks across the country about healthcare policy, I'm always struck by how much of a challenge they have, advocates have, consumers have, to get the care that they need. Cost, quality, affordability. And I thought about, Secretary, here in Massachusetts, though we have our challenges, compared to the rest of the country, we're doing pretty good. So I just wanted to state that because I think it's significant to pay attention to that. So we have a special place, and credit to Governor Baker and his comment today around how we responded to COVID as well. Colin and I jokingly said we've been on every task force known to man and woman in the last 2.5 years, no exaggeration. Cities, towns, legislature, DPH. So we became best buddies through that process. But I can tell you, equity was front and center. It allowed some of us to have a voice in the room. And as Jim Hunt, my predecessor, used to say, if you're not at the table, you're on the table or you're on the menu. So I want to say thank you for that. The Community Health Center network that I'm fortunate to represent provides access to comprehensive primary care for over 1 million patients now. In fact, last year, as you know, Secretary, health centers provided 4.7 million medical, dental, mental health, substance use, vision, and other enabling visits to residents from 96% of the state zip code. I might shock some people, 96% of the state zip codes. We have been blessed with visionary and committed health center leaders that many of you know so well across the Commonwealth, their staff and their boards, and many of those board members are consumers. And yet we know right here, right there in plain sight lie the inequities which we see and hear about from health center members every day. What we hear about are provider and staff vacancies, driven by longstanding reimbursement variation on both the government and commercial side. On the heels of the Baker administration's historic investment in mass health reimbursement. Thank you, Secretary. Thank you, Secretary Sutters and Governor Baker and Amanda Krasselcraft for that investment. These vacancies at health centers and our safety net provider colleagues have real world impacts. Wait lists for a provider or an appointment, especially in areas like behavioral health and dental, or needing to travel a longer distance when a local site closes. When patients can't get access to care in a high quality primary care setting close to home, they often seek higher costs, lower value, or episodic care. What's the effect? Higher costs for worse outcomes. And who is most impacted by these inequities? No surprise to anyone in this room. Our Black and brown residents, the low income, those living in rural communities, our farm workers, and our unhoused residents, the very patients, according to the late Senator Kennedy, for whom health centers were invented. That is what I think is the answer to your question.
Thank you. Thank you. Can I turn to you, Bill?
Thank you. Thank you for the invitation. I happen to have been here 10 years ago out in UMass, and you people were nice enough to invite me back once. So hopefully third time's a charm. I will say, hearing the question and what we're experiencing, a lot of it you've already seen and heard from the prior panelists, but it's really, the shifting of the cost is really happening down in the trenches. Higher deductibles and copays are being added or increased to people's plans. In some cases, spouses are being asked removed from the plan so that they have to go elsewhere to purchase insurance. We all saw the slide that showed that HMOs at the beginning of 2022 was about 8% increase. We have recently received the dreaded call from our broker as to what's going to happen in 2023, and our prices are going up a little over 18%. When I look back over the 9 years, without making any plan changes, our increase averaged 12% per year. We then subsequently made plan changes similar to what I just mentioned, which brought it down to about 8%. And as you also saw, for that same time, COLA, cost of living, that was issued by the Bureau of Labor Statistics for that same period was about 2.7%. So the obvious is it's just obviously not sustainable. So what's also happened in our arena is for the last couple of years, although we've been out to bid with as many as 15 different providers, we've only received one quote, and that comes from the incumbent because we are a fully insured plan. And one might say, well, are you just got unfortunate, a lot of unhealthy people? And the overall answer to that is no. We have one individual who has an orphan drug that costs about $100,000 per month, $1.2 million per year. And we've been paying that through our policy we are now entering the 6th year. So and we ended up owning it, which then really prevents us from doing competitive bids for the rest of our people in the overall program. So the points about more transparency into those drugs that I think it was $100,000 launch and what they cost and how that gets approached is something that I hope that the HBC has the time to sort of focus in on.
Good, thank you. And Colin Killick.
Thank you so much to all of you for this invitation. I think that people with disabilities are in a really unique and really difficult position when it comes to this issue because we are impacted both by high healthcare costs and by many of the proposed solutions to high healthcare costs. We are a community. Healthcare, social determinants of health are talked about all the time, and certainly those have tremendous impacts on people with disabilities. We have a rate of homelessness that's more than twice that of the general population. We have the highest rate of poverty of any American minority group, and those things obviously impact health. But we also have something of the reverse, where the extent to which people with disabilities are able to get high quality healthcare determines the extent to which they can participate in society. Getting a personal care attendant or a power wheelchair or access to the right drug is the difference between living in the community and living in a nursing home, or in some tragic cases, not living at all. So for those people we work with who are on private insurance, which is a decent portion of the disability population, certainly, yes, we're seeing increased costs of drugs go up. Many of the most common disabilities, diabetes being one, of course, there's been a great deal of coverage around the price of insulin. Medical supply costs, certainly, and especially also medical supply chain disruptions have been a major issue in our community. I know someone we work with who is boiling her ventilator circuits, the tubing that goes from her ventilator into her throat, because she has been unable to get fresh supplies of tubing. And so these that are designed to be disposable, she's having to reuse over and over again simply to be able to breathe. So that's been a significant point. But then I think both for people with disabilities on private insurance and the bulk of the people who we work with who are on mass health, there's the question of, are rising prices going to lead to our people losing care? It's an unavoidable fact that many people with disabilities—
Not while I'm secretary.
Thank you. And I was reflecting the other night, it was the gubernatorial debate in Georgia, and Stacey Abrams talking about, pledging, if she were governor, to clear the tens of thousands of people on waiting lists for home and community-based services there. The fact that there is no such waiting list in Massachusetts is a real testament to your work, Madam Secretary, and to Mass Health and the entire team, Amanda and her whole team there. We are lucky in Massachusetts to have a wide variety of services available, and we're lucky to have more spent on services in the community than services in nursing homes. I frequently talk to people about, let's not pay for misery, right? Let's not pay more for solutions which deprive people of their dignity, and as we've seen with COVID, expose them to great risk, than we could be for solutions which preserve dignity and independence and safety. But this is a threat, and it's a threat to people with disabilities in private insurance as well, in terms of, are we going to see the rise of things like, increased use of fail first measures, making someone try the cheapest drug, the cheapest treatment first, rather than the one the doctor prescribes. Obviously, in some cases, if there are multiple drugs with the same effectiveness, there's no reason, they're dealing with copycats and that sort of thing. But we've seen cases, the tragic death of Carrie Ann Lucas several years ago was a beloved disability activist in Colorado who was on private insurance, and her insurer denied the inhaled antibiotic she was prescribed, forced her to take a more common, cheaper antibiotic instead, and she had complications which led to several months of hospitalization and ultimately her death. I think my overall message on this would be, yes, rising costs impact our community, and rising costs constrain our community's options. To Bill's point, talking about health insurance costs, our organization has 25 employees, 75% of whom are people with disabilities. We've never been able to offer a health plan. We've tried, but because of our employees' disabilities, the premiums we're quoted are so astronomical that neither us nor our employees could possibly afford them. So we instead subsidize for our employees who aren't on Mass Health, we subsidize the plans that they purchase through the connector. But we'd like to offer that as a benefit, but we couldn't do so and hire the people we want to hire, the people with the lived experience that they have. So I think our community is impacted by this, and I think there are ways forward which can both lower costs and increase quality. Things like investing in peer supports in our mental health system, which for many people with mental health diagnoses provide better, less carceral, more supportive options, and also happen to cost a lot less. I think getting people out of nursing homes and into living in the community. But I think, and of course, clearing layers of bureaucracy, clearing unnecessary denials, cases where someone, gets denied care and goes through layer and layer of appeals and ultimately is approved when that person could have been approved in the first place. Or approving someone for an inflatable cushion to stop a pressure sore instead of paying tens of thousands for the pressure sore itself. So I'd say if we can move in that direction, our community will benefit on both sides. What I would urge you is to ensure we don't move in the direction of penalizing those whose conditions make their care expensive in an effort to lower the cost of care.
Thank you. Turning to Amy Rosenthal, again, what impact do you see from increasing healthcare costs on consumers and patients?
Very well. Thank you for having me here on this 10-year anniversary, and thank you to all the commissioners for your incredible work over the past 10 years, to the staff, and to under David Seltz's leadership. I'm excited, Chair DeVoe, to see you in this role and excited to work with you. And the last time I was here in person, I respectfully noted to the commissioners the importance of thinking about the makeup of this commission and that it too reflect the gender, racial, and ethnic diversity of the people that we are seeking to serve. And I would flag that again here this time, just the importance of that. What I think about every day and what Healthcare for All as an organization continually focuses on is the experience of the people of the Commonwealth, and thinking about the benchmark as it's designed in Chapter 224 and whether that's been a sufficient tool for helping the people. In a nutshell, I would say that the system has probably seen greater benefit from the cost containment efforts than the people themselves. Member cost sharing in terms of what people pay in copays and deductibles, when they go to the doctor, when they pick up a prescription, These costs have consistently increased and at a faster rate than overall healthcare costs in the state. Member cost sharing grew between 4.4 and 5.7% every year for the 5 years between 2014 and 2018, in each case at a rate greater than the overall healthcare cost growth. And in the last 2 years, the premiums also grew at 5.7 and 5.6%, again, a growth rate higher than the benchmark. We've also seen particularly concerning trends in our market for the individual and small employer plans, with premiums rising between 4.7 and 7.9% each year for the past 4 years, according to the Division of Insurance. And all of these have been higher than the benchmark, whether you look at it at 3.6% or 3.1%. Further, CHIA's health insurance survey has consistently found a quarter of residents reported challenges affording care. And those numbers have crept up recently, with the most recent survey showing 41% of Massachusetts residents reported that their families faced affordability issues in the past year. Both CHIA and a separate survey in 2021 found significant racial disparities when it comes to affording care. I cannot underscore this point enough, with Black and Hispanic or Latinx residents more likely to report challenges. 75% of Black adults and 68% of Hispanic or Latinx adults in Massachusetts face affordability challenges, compared to only 46% of white adults. So I asked myself, how do these statistics line up with what we experience at Healthcare for All and what we hear on our helpline? So let's take a look at Arturo and his wife, who called us earlier this year. They don't have employer insurance, and they purchase insurance on the connector for around $300 a month. Unfortunately, the plan has a $4,000 deductible, leaving Arturo's family of 3 with burdensome out-of-pocket costs. Recently, he had to pay $260 out of pocket just for routine blood work. And now the family's worried about affording future doctor visits. They'd like to find a less costly plan, but can't afford higher premiums. I'll share one more story. Ira, a young school teacher who's at high risk for COVID because of her asthma, had to pay pays $350 a month for a health plan on the connector that has a $2,000 deductible. Because of her high deductible plan, out-of-pocket costs add up quickly for her. Her inhaler, nebulizer, allergy shots cost anywhere between $200 and $600 a month. And the fear of additional costs has discouraged Ira from seeking treatment for her other conditions related to her mental health conditions. So if the question is, how are the people faring, I would clearly say that we think that there is more work to be done in the years to come. Thank you.
Thank you. Let me open it up to questions from the commissioners. Commissioner Brewer?
Thanks, Madam Chair, and thank you for your, not just for your testimony, but for your work, all 4 of you. It's important and moving to listen to you. So you've put a face on the statistics that David Auerbach shared with us. And to be blunt, we have a lot to be proud of in the Commonwealth, but we're losing ground. We're losing ground on cost. And that loss of ground is being passed through even more and more to individuals, and even more and more especially to vulnerable individuals. So that's what I'm hearing you say. And this is real pain. So the commission's here to help that. I guess I need to take you into the weeds a little bit here. And if you don't mind, if you want to pass, please do. But we have recommendations. Dave, our executive director, presented recommendations. That's actually the 3rd year in a row for pretty much the same recommendations, which we're passing over to the executive and the legislature. What would you most like to see acted on among our regulations, among our recommendations? I'm not going to put you on, give you a pop quiz. I have my crib sheet here, but the basic categories are strength and accountability, so we can hold the providers' feet to the fire more on cost increases. A second is an opportunity to focus, to constrain excessive prices, especially in places where those prices are high. Right now, our jurisdiction has to, it prevents us from targeting at the level that we are asking for. The third is on emphasize drugs, focus on pharmaceutical spending with a set of potential interventions there. The fourth is to move upstream to health plans and increase their accountability with a whole bunch of targets and constraints. The fifth is really cross-cutting for all of the above, emphasize health equity, that focus on equity as a major theme. The sixth is anything else you want to say, miscellaneous. So I mean, if we were going to double down on our recommendations and pound the table a little harder on one or two of them, what would be your favorite? Mr. Curry, you want to start?
Yeah, I knew you'd pick on me first.
Do it alphabetical.
Exactly. You know, it's so funny. My kids know that I typically say the answer is D, all of the above. I won't do that here, though. I'll say that my answer would be health equity. People, no surprise to anyone in this room, that I believe we've ignored health equity in Massachusetts, and that has a cost implication. I know testifying after us is a good friend of mine, Andrew Dreyfus from Blue Cross, where I worked for 16 years. And in a meeting with him not too long ago, Jeffrey Sanchez, myself, Manny Lopes, Juan LaPera, we're in a meeting with him, and we talked about health reform, which many of you were involved in. And Andrew said, you got to make a case, a business case for health equity, because we made a business case for health reform. What does it cost Massachusetts to have high numbers of Black and brown immigrant poor citizens suffering from disease and dying of higher rates? And I know we all sat there for a second to take that in, because we've never done a business case on health equity in Massachusetts. What does it mean in terms of Black and brown citizens who are on leave from work or who die and are not serving out their role at a particular employer? What does it mean in terms of the rating, as Colin talked about, in terms of your premium for an employer? What does it mean as we talk for the broader conversation around emergency room use and inpatient days, now drilling down to race and ethnicity data? To me, that's the most pressing issue, because I think there's a lot of savings, and by savings and costs, but saving in lives matters more to me.
Thank you.
I would vote for moving towards the pharmaceutical analysis on drug cost and being able to do a deeper dive. It's my understanding that CHEA obviously gets a lot of data and has made it into some great information. That's hats off to all of you for doing that. But it's also my understanding that CHEA only gets about 50% of what's actually happening out there because of some court case that people stand behind that self-insured don't need to share. I don't understand it, but that's a different discussion for a different day. But anything around the administrative side, when it comes to a standard EOB, even talked about having a standard clearing, well, I'll call it a clearinghouse. We have the Department of Revenue. We've got the Registry of Motor Vehicles. They know a lot about all of us. Why can't we take a platform that's one of the major insurance companies is using to process claims, to have standard forms, to have standardization, so everybody's information is in one spot? You've all heard the commercials on the radio and says, ask your doctor, or tell your doctor if you're having so-and-so. Well, your doctor should know, or somebody should know, and if that information was in one spot, it would prove a lot of positive results, and I think those would be my top priorities.
I think unsurprisingly, I would say equity as well, although I do have a point I'll come back to about pharmaceuticals. Michael mentioned data, and I think first piece is having the data. We were on the Health Equity Advisory Group to the Department of Public Health together as COVID really raged. I was, we were in the difficult position in the disability community that, and I'm not trying to pick on DPH, this is just an example, but they hadn't been collecting any disability data in their demographic surveys. So we have no idea how many people with disabilities died of COVID in Massachusetts. We know, that thousands, essentially all of whom were disabled, died in institutions, in nursing homes and in mental health facilities and in prisons, et cetera. But in the community, we don't know because that information wasn't being collected. And so ensuring that we see that, and it happens with other communities as well. Raquel Halsey from the North American Indian Center of Boston was on that panel with us and was frequently justifiably upset because so few people who are Native Americans and Alaska Natives had been reached that category wouldn't be reported. They didn't reach a sufficient sample size to, have to be able to report it. So that's the piece. And I would say, right, looking at the communities that are being hardest hit, right, that are already facing the greatest trauma, the greatest impacts from pollution, the greatest impacts from homelessness, and not piling on top of them even further these costs, these difficulties that incur because of costs. So absolutely investing in equity. I would note around pharmaceuticals, I do think that this commission has a really exciting potential role to play. I think some of you have heard from me, certainly David can say that the commission staff have heard a lot from me over the years on this question, because the disability community has had grave concerns around some of the metrics that are used in healthcare around analysis of pharmaceuticals and their potential to discriminate against people with disabilities. There has actually been a bit of movement on that recently. We actually filed a healthcare non-discrimination bill in the legislature last session, which was reported favorably. It didn't ultimately pass, but we were able to negotiate a compromise position with some of the advocates on the cost effectiveness side for how to advance affordability, price analysis in ways that don't discriminate against people with disabilities. It's a crack. It's a little bit of daylight, but the potential is there. And I think this commission could play an exciting role in leading, not just in Massachusetts, but nationally on this issue, in investing in that area, helping to develop the kinds of new measures that we really need to effectively tackle prescription drug prices in an equitable way.
So I unfortunately won't give you just one thing, but I agree, of course, with always putting an equity lens on everything that we do. I go back to the Chapter 58, the way we got things done and the way we think about things in Massachusetts is with shared responsibility. And I don't think we can tackle cost containment issues without shared responsibility. And to us, Healthcare for All, we think about it in terms of the three big industry groups. And so I think you can't just pick one piece and single out one industry group. And so I would offer the following. So I absolutely think the pharmaceutical manufacturers and PBMs need to be coming into this process for sure and be held accountable for the increases that we've been seeing. So again, I think I don't remember who alluded to, I think it was David, the good work that's been happening at Mass Health. We know this is possible to do. We should be bringing them into the fold. So that's kind of bucket number one. Bucket number two, in terms of thinking about hospital systems, I think the Health Policy Commission has been constrained by the limitations. I think David talked about this earlier about what factors we can be using for referring people into the performance improvement plan process. I think we need to be thinking about broadening those measures. One size does not fit all. The referrals need to be more nuanced, thinking about things like taking into account non-risk adjusted costs, provider type, relative price variation, et cetera. I would also say it's a good first step that we've had our first performance improvement plan, big important milestone. I think it's a little unclear as to whether we'll be able to measure whether the cost savings are sufficient. I think we need to make sure that there's accountability moving forward for when the next PIP happens, not that there wasn't in this one, but I think we need to keep that momentum moving, thinking about models like what we've seen in California about penalties, and thinking about that I think is important. Thinking about insurance companies, I think we need to be thinking about, I think you all could be thinking about a single measure that looks at consumer costs and reporting on that each year as a way of thinking about things. And then I think we also really want to encourage the Division of Insurance and the rate review process to be thinking about taking affordability into account when looking at rates. So those would be the things I would say. In the other bucket, I would say one last thing, which is we heard about the good work of the Health Connector. The House and Senate in their budget this year passed a pilot program to expand Connector Care up to 500% of the federal poverty level using federal dollars that have come into the state, into the Commonwealth Care Trust Fund. Connector Care is a highly efficient, cost-effective program. I think we should be building on the model of success that we have here in Massachusetts and looking at ways of running pilots like this, especially when they're financed from the federal government, and really be building off of those types of successful models.
Thanks. Amy, could you just clarify the California benchmark that we should be looking at, the enforcement there?
So there's the new law in California has provisions in terms of what the penalties are for exceeding the benchmark that has to do with I'm not going to get it exactly right, but it's actual the dollar amount, I think, that you go over the benchmark that is the penalty. So it's a pretty significant, I think I got that right, yeah. It's a pretty significant increase compared to the $500,000 penalty that we have here. But something certainly to explore and look at as they're moving forward with it and explore here.
Thank you all.
Thank you. Secretary Sanders.
Well, the good news, Michael and Colin, I haven't come up with any new task forces. Your voice during that time was extraordinarily important during very difficult conversations. I just want to publicly acknowledge that. And I remember some of those very painful conversations because I was involved in those. I just want to comment on two things. And one is equity and the data. And pharmacy, if I can, for just a second. And quite honestly, I was during, I think what might have been one of the press conferences Michael was at, that we actually had to put out a public health order requiring providers, you're not outing public health because public health can only report the data that's reported to them. And that we actually had to put out a public health order requiring providers to provide the data that was actually already required. And it was like, and I finally, and I overruled actually the wonderful Department of Public Health and basically said, we're going to put out a public health order basically shaming people to provide the data. Because if you don't provide the data, you can't measure success. And I would encourage all of us, as Amy would say, the shared responsibility of agreeing on what the data is on race and ethnicity and disability, so that across payers, providers, I know everyone in this room who's not involved in the space will say, well, of course, that's common sense. It's actually because of the systems, because of just whatever, it is hard to actually make that change. And I would just like put that out there on all the other parts of equity that are so important. And on pharmacy, and we all have shared responsibilities, Amy would say. I want to give both Governor Baker and the legislature a shout out for the courage in giving Mass Health the authority to negotiate directly with pharmaceutical companies. And I just want to give you one. So in Mass Health, gross pharmacy spend grew 55% from 2015 to 21, as compared to 29% increase across the entire Mass Health benefit program. So 55 versus 29. We have maintained a flat post-rebate growth during that period as a result of the authorities we requested and negotiated with the legislature. Flat. I have a graph that I could show you that shows what the growth would be. And that's, of course, with new drugs coming onto the Mass Health program. So there are ways to manage cost without a negative impact on consumers. And I would just encourage all of us, and Mass Health is now 2.3 members of the Commonwealth of Massachusetts, that there are ways that we can do this that do not cut into profits, maintains consumer access, and curtails or mitigates costs. So I would just put that out to all of us to consider. Sorry, that was more of a
Thank
statement
you.
than a question.
Other comments, questions? Yeah.
Oh, look at that. Very nice. Thank you so much for being here. First, I just wanted to say quickly to Colin, thanks for being here. It's a really important voice to add to the discussion, particularly with the loss of Paul Spooner, an amazing disability rights leader, and he'd be really proud of the work that you're doing here today and bringing that voice forward. So I really appreciate that. Sorry, didn't want to make it too much, but just wanted to recognize the amazing work that he has done and that you're carrying that vision forward, which is really important. So keep up the great work. I just want to follow up with you, Michael, about the issues of racial and economic justice, and particularly in the healthcare space. Clearly, data is a big part of it, benchmarking the work. I'm just wondering, from your perspective and the work that you're doing, the groups that you brought together, what have you seen as the structural or institutional barriers or reasons for these outcomes in our healthcare system, and kind of what are some of the recommendations that you've thought about that could help inform some of the benchmarks and targets that we're trying to reach as a health policy commission? And just, again, speaking to the institutional structural issues that have led to these outcomes for that population.
Thank you, Tim, for that. It's so funny because I was telling my staff how exhausted I am because I was on 10 panels this week on this exact topic, including ACHE. Dr. James did a presentation and walked through what some of the phenomenal work that BMC is doing around racial justice, D&I, maternal health. And I remember in the conversation with her and with Kate Walsh, I just use them as an example, but others are doing it too. It was about identifying the systemic racism. That if we can't name it, then we can't deal with it. And Kate said, you know, what really moved me, and I'm quoting Kate, so she's here and I misquote her, I'm sorry. But she talked about hiring the right people, right? Systems change when the right people are in the right place for the right time. Trina Martin, Dr. Thea James, Elena, are 3 leaders at BMC that's pushing Kate and the team around doing things disruptive. I know we don't like that word, but Chapter 58 was disruptive. If we want to do something around health equity, we're going to have to be disruptive. That means all of us, when we talk about all of the recommendations of the Health Policy Commission, the health plans, the hospitals, teaching, community health centers, pharma, a diagnostic organization, we all got to figure out how to do this in a disruptive way. It starts with hiring the right people so that they can hold us accountable at the table and ask that question. I say, Secretary, often for Colin and I, we were the skunks of the party raising our hand every time an equity issue came up, right? Because nobody wants to hear it. We can't pay for it. It's inconvenient. It's disruptive. It's not expedient, but we still raised our hand anyway. So I think part of that systemic change has come with having the right people in the right room. And then 2, thinking differently about our systems, that we can actually solve for disease in communities. And folks in this room, forgive me, but those who've heard me say it, Rebecca Lee Crumpler, the first African-American physician, 1864, she said, they seem to forget there's a cause for every ailment and we can do something about it. We can solve it, is what she said, 1864, before we even talk about social determinants of health. So I think we really need to be courageous about it. I think I'm encouraged by Dr. James's presentation, and I'll talk in a second about what I heard in New Bedford last night with a packed room of community folk who are engaging in this issue of health disparities. I think the change comes from the bottom up, not from the top down. For folks like Amy and Healthcare for All and MPHA and organizations that are really forcing us to think differently, I think that's how we'll change. And SEIU.
Would it be all right if I jump in on this one too? We've been doing our legislative planning for the next session, and we started off the entire experience with our policy team sitting for 4 hours, not allowed to talk. And we were only listening from our helpline counselors. We now have 7 helpline counselors who are taking calls in 5 languages, about 25,000 calls a year, and our community outreach workers who are out in the community every day. And we just listen to them, identify the issues that they're hearing from the most. So one was definitely, there was this distrust of the healthcare system that was real and that people were hearing, our folks were hearing about a lot. And I think we're eager to see the work of the Health Equity Compact and others that are thinking about ideas in that. That's for sure one issue. The other thing that we heard a lot about was language access and about the increased costs that are coming because people are not able to like move around the healthcare system and use it in the way that they're supposed to. And I'll just give you 2 examples. So one is our helpline counselors have moved from just, unfortunately, I shouldn't publicize this, but they've been moving from like answering questions on enrollment insurance to now finding that they have to field calls to help people set up appointments because they cannot find appointments they can't communicate in the language in which they're able to speak. The problem then comes when the doctor's office then calls that person to confirm the appointment and they can't confirm it. They show up 2 days later and the appointment's been canceled because it hasn't been confirmed. And this is happening dozens of times a week, at least with what we're interacting. The other piece that is happening is now we are getting people calling us back a couple months later saying, I was never able to get an appointment with my primary care doctor. I now need prenatal care because I'm now pregnant because I wasn't able to get my birth control. And we're getting those calls every single week. And so, you know, these language access issues have huge ramifications for the individuals and their families. There's also obviously system costs that go along with all of this. And thinking about language access as a piece of this, I think, is something that we all need to be really focused on and thinking about.
And just very quickly to add, Michael, I really appreciated your point about needing to name the problem, right? And naming systemic racism and amen to that. And I think the cost of discrimination is a real one to be considered. We're lucky in Massachusetts to have Dr. Lisa Iazzoni and her team who doing really critical policy work, including on disability and disability discrimination in the medical system. And she completed a report last year that of a survey of 714 physicians across the country, 82.4% reported believing that people with disabilities have an inherently lower quality of life than people who do not have disabilities. And only 40.7% of those same physicians reported being very confident about their ability to provide people with disabilities the same quality of care that their patients without disabilities received. And we see this play out. Most medical practices do not have accessible scales, so that disabled patients cannot, a patient in a wheelchair cannot be weighed. A huge share of dentists' offices are not wheelchair accessible. So as a community, we have really impacted oral health. Gynecological care is a similar story. So you think about the unmet needs, the crises that happen because people are getting inadequate care, and the costs of discrimination, of patients not being taken seriously or being written off as inherent, of inherently lower quality. And that is something that needs to be considered through this process.
Thank you.
I want to thank all of you for joining us today. Really important points that each of you are bringing up. My question is actually for Bill. As the chair of the AIM Healthcare Cost and Quality Committee, you can answer a question that I received from one of my team members a couple of weeks ago, and I think it applies to all the employees across the state. And he said to me, I know the company's running into expenses that are increasing because of inflation. And my concern is, how will that impact my annual increase in compensation and healthcare? Will I receive less healthcare coverage? Will I receive a lower increase in pay? How is that going to work? And I had to answer it from my perspective. We're in a small company, and I provided that. But I'm willing to bet employees across the state are all interested in how does this work? And from the feedback that you get from the members, both from small companies and large companies, I'm very interested in what you hear.
It is a huge problem. There's no doubt about it. And what we're seeing, and people have reported, again, a lot to the cost sharing. So if somebody sort of believes they are healthy, the deductibles, increase in copays isn't as much of an issue to them. People with large families obviously look at it differently. It's clearly impacting a company's ability to grow. If they've only got $1 to spend, where are they spending it? As Michael was saying, people, we're all under this pressure. That's one of the huge issues here, is where are the people going to come from to continue to maintain the business, grow the business, and there's not really one answer. It's more fact-based, that every company has to adjust itself accordingly. Colin mentioned that they're not even able to offer health insurance because of the pricing, and that, I think, is some of what is being given up and at different levels across the state.
Are you finding that more firms are adopting a high deductible policy?
Yes.
Than we have in the past?
Yes. Yes.
Because of the inflation level, you're seeing a bigger increase this year? Yeah.
Yes, I believe the answer to that is, or across the board, is yes. And some will then ultimately argue then people are then kicking the can further down the road when it comes to preventive care, which will then ultimately lead somebody needing more expensive care and really end up in the emergency room.
Thanks, Bill.
Thank you. Time for one final question for the panel. Commissioner Howe?
I think mine's a little redundant with what Bill Dr. Berwick had to say earlier, but if we could go into a lightning round at this point in time. Our next panel are health system leaders, and if you could just say in a few words the most important thing that you think they need to hear from you, each of you.
Repeat the question.
Well, if there's one thought synthesized that you want to convey to our incoming panel, which are health system leaders, what
Okay.
would that be?
Yeah, I think that there's a few things. So one is, and I mentioned and alluded to it earlier, is around reimbursement and how critical that is. So I think from a reimbursement standpoint, we as health centers, but I think providers generally are trying to make sure that we get fair reimbursement for the care we provide. As Secretary Sutters and I've talked about it many times, that we provide more care than is expected of us, right? And that care is often not reimbursed. And then how do we make sure that we are reimbursed in a way that we can meet the growing demand for care, the acute cases and conditions that we treat in the communities where we're located, 52 across the state. I would say to our systems that we need to come up with a strategy, and I'm fortunate in the year and a half I've been in this role that I have good relationships with the heads of our systems. So that conversation is underway, just like we had that with the governor and the secretary. I look forward to figuring out a way how we can get that equitable reimbursement. And then the rest of it is around going upstream, because I think we have to do that together. Everyone's talking about this 80-20 now, 20% of what drive your health status. I had a debate with my good friend Tom Sequist at MGB. A group of us have been really debating this issue of how do we do this? How do we bring down costs? And that dilemma, right? Cost, quality, access, equity, choice, often competing. You influence one, it impacts the other. I think I teach health policy. I think of William Kissick's Iron Triangle when he talks about the conflict that exists. I think we have to do that together. So I think the critical part is where we invest. And some would say it's not about more money. I argue that that's not true, that if you want to do something about equity, you have to spend more. Right? You have to spend more, and maybe using a statement I also use with my kids, sometimes you take 5 steps back to take 20 steps forward. Let's invest in the places where we know long-term it will save costs, and we'll see that those indicators start to change.
Wonderful.
In my opinion, whether it's the provider or the insurance company, it's transparency. We still hear periodically, well, it only cost me $150 to go to the emergency room. Well, not exactly. And so that is clearly one issue. I agree with Michael. A lot of this has to be from the bottom up, and we need to make that information readily available to everybody so that they better understand it. When I was talking about our orphan drug, I neglected to say it was coming through as a J code and buried in the medical. So that whole transparency issue and the numbers we're quoting about pharmaceutical, I'm not truly sure. I default to Mr. Campbell as to whether he's able to sort of cull that out. But to me, it's transparency. And one other sort of off the record suggestion would be, we have catastrophic flood insurance for when Mother Nature decides that she wants to not be friends with us. We should look at catastrophic coverage for some of these unusual events that last multiple years as opposed to a very short time period.
Can I just ask, how many employees do you have?
We have 350 employees. We insure approximately 600 lives.
Fully insured.
Fully insured,
Fully
yes,
insured,
ma'am.
yeah. And the other point about $150 ER visit, we aren't getting EOBs mailed to the home any longer. We're being asked to access our health records online. A lot of people don't do that. And you used to get the EOB and you'd see there was a $3,000 charge, you had a $150 copay. So we're losing that, even people running into what the actual cost of an event might be.
I'd advocate that they email it.
Thank you.
You're welcome.
There's a concept in the disability movement that we believe in, is the idea of user expertise, the people who live inside systems and deal with the ways in which they are complex and sometimes broken, understand them in ways that not even the people who design them do. And so I would say to both the providers and the insurers, your patients, your members are experts in your systems and in their own needs, and engage them, listen to them, ask them what's not working and find ways to correct it, and to get them involved in their own care. We have in Massachusetts an innovative program, One Care, for people with who are dually eligible, have complex disabilities, and there's a deep and abiding partnership between the community and Mass Health to make that program work. And one of its key aspects, and one that's been the hardest to maintain, is these care plans, right? That members should be writing a care plan, or just what goals should their healthcare be helping them to achieve. And that concept, I think, is one that could be applied much more broadly in the world of healthcare, is giving people that ownership and treating them as, as the experts on what they need, where they want to go, regarding in that way.
Thank you. So my job at Healthcare for All would be a lot easier if I just really focused on whatever we needed to do to make consumers' experience better. But in the 5 years that I've been here, we have not just thrown out proposals that just cost a lot of money that we're expecting everybody to just pay for. And we offer some of those proposals, but we offer savings as well. And so we do focus on these system costs because we know that's the fiscally responsible thing to do. And we are very grateful that we've had some industry partners who have partnered with us on this. I would say, however, though, in this concept of shared responsibility, it would be really great for the different industry groups with consumer advocates to come to the table. It doesn't have to be the perfect proposal. We just need a meaningful proposal that we can try to move in the upcoming years. And then I'd ask those industry groups to put the full weight and force of their industry organization behind the proposal to try to get it across the finish line. And so I would respectfully ask them, let's go. Let's do that.
Go ahead.
And I'd be remiss if I got out of here and did not mention this. The governor's proposal, one of his first healthcare proposals out the box, was the increased investment in primary care and behavioral health. Very disappointed that it didn't go anywhere. I think many of us in the health center community and many of us in behavioral health feel like that was a huge step in the right direction. So I think we need to revisit that. I know we're in the waning days of the Baker administration. I hope that doesn't drop as well.
Thank you.
Perfect. Thank you so much. You absolutely did what we were hoping, which is to bring these issues around affordability, equity, and access to life for us, and to put a set of practical and real proposals on the table, and set us up very well for our next panel with the hospital and physician delivery systems and the health plans in terms of where we go from here. So thank you so much, and appreciate you being here in person today.
Thank you.
Thank you.
No, you work hard. You need some more bunnies. You need as many bunnies as you can.
Hi, how are you?
I'll see you quick.
Andrew, how are you?
Sure.
Madam Chair.
Hi, Andrew. Thank you so much for coming.
Colin, I'm sorry. It's all right. It's all right, Colin. No, you're not.
Not at all. Not at all.
Interesting, it may work even if it doesn't actually.
Hey there. How are you?
Thank you, Colin.
Thank you, Colin. Thanks so much.
Thank you very much.
Nice to meet you.
Good job.
Not in here, huh?
All right.
Got more to
From Colin. Just made me think of things I didn't think about.
Thank you, and welcome.
Send you some better ideas for novels.
Hello, great to see you.
Andrew,
Thank
good to
you.
see you.
How's your life?
Welcome to our second panel.
Okay, I don't have a chair, so can I
Want to sit down? What are we doing, sliding down?
We're making your swan song.
Good, thank you. Great. Thank you so much. Welcome to our second panel. Let me start by introducing this panel's purpose, our goals, and each of the panelists. The theme of our second panel is, what is the path forward for Massachusetts? We're looking forward to hearing from our leaders on the current challenges and their recommended approaches to promote affordability and to address cost growth in Massachusetts. We want to welcome Dr. Kevin Churchwell, who's the President and CEO of Boston Children's Hospital, Dr. Eric Dixon, who's the President and CEO of UMass Memorial Medical Center, Andrew Dreyfus, President and CEO of Blue Cross Blue Shield of Massachusetts, Kane Hayes, President and CEO of Point 32 Health, and Dr. Ann Klebanski, President and CEO of Mass General Brigham. Now I'd like to ask Lois Johnson, our General Counsel, to swear in the witnesses.
Hey.
Swear or affirm that the testimony you will provide today is the truth.
I do.
Thank you. Before we move to the panel discussion, we'd like to ask Director Sells to provide some background.
It makes it pretty damn clear.
Great. Thank you, Chair DeVoe, and welcome panelists. Before we dive into the panel, I did want to share just a few more data points to help inform this conversation and dialogue today. So as I mentioned at the beginning of the hearing, one of the key aspects of this hearing every year is compiling testimony from a broad range of different provider organizations and health plans. We call it pre-file testimony. And so this year we asked around some of the challenges that organizations are facing, the strategies that they're putting in place, and the policy recommendations they would recommend to the Health Policy Commission. So just wanted to share a little bit of what we heard from the community here in Massachusetts. So this first slide is just a compilation of what we heard from health plans, all the major health plans. And in terms of some of the challenges, a majority of health plans identified the cost of pharmaceuticals as being something that they were very concerned about. In terms of strategies, we saw more than 3/4 of health plans pointed to concepts around different types of benefit design, tiered and limited network products, and the promotion of alternative payment methodologies. When we asked our big provider systems, some of these same questions, we heard different answers, as you might expect. A vast majority of our provider systems highlighted the difficulties in workforce and recruitment and retention of that workforce as a major challenge and one of the most important things that they're focused on right now. In addition, we heard from payers and our providers around their efforts to increase data collection to help promote health equity. So we're interested to hear from this panelist about some of your reflections about both the challenges, the strategies, and the policy recommendations. And I think we've put together just a really incredible panel. And to reflect on that a little bit more, we wanted to put together just a few data points just showing how important your institutions are to healthcare in Massachusetts. So of the 3 big provider systems we have here today, you provide care to 1 in 3 commercially insured adults in Massachusetts and 50% of commercially insured children. You employ more than 10,000 physicians and have annual revenue of over $16 billion. And for our 2 health plans here today, you represent almost 60% of the commercial market. So we're hopeful that, as Chair DeVoe said, this is really the right group to help us think about the path forward. So with that, I will turn it back over to you, Chair DeVoe.
Thank you. Thanks so much, Director Seltz. So we'd like to ask each of our panelists to respond to 2 questions. Really, you have a deep understanding of the issues around affordability, and you've also heard from our previous panel about their priorities and concerns. And we'd like you to give us your thoughts on approaches around affordability And what are the most significant challenges you're facing in addressing cost control? So I'll ask each of you to respond to that. Could I start with you, Dr. Churchwell?
Well, thank you for the opportunity to speak today. When we ask the question, what are the most significant challenges we're facing? This is, I would describe, an incredibly unusual time in healthcare, specifically in the healthcare in the Commonwealth. I think we would all agree that we've not been in a normal time. I don't know if there's ever been a normal time for healthcare, but certainly in the last 3 years, this has been incredibly unusual and has created a significant environment where the question around what we're dealing with, what are the significant issues we're dealing with, are really at the forefront. I will tell you that in pediatrics, we have never seen what we are currently seeing with our kids in terms of the onslaught, in terms of the overwhelming issues associated with our kids with behavioral health needs. Now, certainly before COVID occurred, we were seeing some increase in that, increase in the number of kids that were presenting to the hospital. So let's be clear, when they present, by the time they present to the hospital, they're in extremis. They have basically failed, the system has failed them, right? In terms of having come to the hospital for care, for treatment. And kids were coming to us for issues around depression, issues around anxiety, issues around suicide, ideation, suicide, expressing thoughts around suicide. With COVID, what occurred, and we're still not totally clear about all the issues associated with it, what has occurred is just an overwhelming part of the number of children that are presenting. Prior to COVID at Boston Children's, we were busy when we would see upwards of about 20 kids a day with these issues. Today, it's over 100. And Eric, I would say that that's just not idiosyncratic to us, but it's across the Commonwealth. And so now it's a system that was not prepared for this, a system that was not staffed for it, did not have the continuum of care that we would want in terms of care for these kids, that we have to adjust to, develop, and respond to. Right now, our caregivers are responding to it just day to day. They respond to it, what's in front of them, trying to get through the day. And we know that's not good enough. We know that we have to create and develop a continuum of care for our kids with these issues. But this is an incredible issue for us. On top of that, we are in a environment where viral illnesses have just come to the forefront in pediatrics. That's not just here at Boston Children's, but it's nationally. You can think about the reasons for that, right? In that for the last 2.5 years or so, everyone had a mask on. And with that, there was actually a decrease in the number of children with viral illness that were presenting with disease. Well, all the masks are off. I'm not saying that's a good thing or a bad thing. I'm just saying all the masks are off. And with that, you now have a number of children who were never exposed, who never had immunity. And so now they're exposed and they're getting ill. And with that, they're presenting to our healthcare system, presenting to our primary care pediatricians, presenting to the community health programs, presenting to the hospitals. And they're presenting in numbers that are just unprecedented. And so that combination of those kids, of our kids with behavioral health, and the kids that throughout the last 2.5 years, we had to defer care and now are presenting needing care, are also combining in a system that is I would describe as a bit of a crisis from that standpoint. So that's what we're sort of dealing with right now, and it's what we're actually managing across the Commonwealth from that standpoint in pediatrics.
Thank you. Dr. Dixon?
Thank you, Madam Chair, and congratulations to the appointment in the position. And congratulations to Secretary Sutters on an amazing job with the 1115 waiver, which I think will really help us drive health equity in this state. I've said many times in many places that I believe healthcare in America and in the state of Massachusetts costs too much and delivers too little to the people it's meant to serve. And that we need to do something about it. I think everybody on the commission agrees with that statement. I think everyone on this panel agrees with that statement. What we may not agree on is exactly what we should do to try to reel in those costs and deliver more to the people that we've sworn to serve. There's a tremendous paper out of Harvard School of Public Health by Irene Papanikolaou, apologies if I butchered her name, that really looked at what the difference is between the US healthcare system and other industrialized nations that cost about half as much as our country. It's administrative waste, it's pharmaceutical costs, and it is the cost of our workforce, nurses and doctors especially. If we don't address those root causes, we will not do anything to the cost of healthcare in this country or in this state. And I think we've put a lot of work into trying to better coordinate care, trying to manage ACOs, of which we have multiple, including the 20,000 covered lives I have for our own employees. But that's fundamentally based on the premise that there's overutilization in healthcare in the United States and in the state. We have less hospitalizations per capita than the rest of the industrialized world. We have less doctors, we have less nurses. We have huge administrative waste. We pay twice as much for pharmaceuticals, and it costs because we charge so much to get a medical education in part, and whether it be in nursing or in medical school, we end up having to pay a lot more for our workforce. Now, so I've been on the record many times saying those are the three things that we should be working to address. And as Dr. Berwick pointed out, the Health Policy Commission has made recommendations in and around those things. Right now, today, as someone who's practiced emergency medicine in the state for the better part of 3 decades, we are in absolute crisis. We are in crisis to the point that I'm 130 beds short at our medical center. That means between sitting in the post-anesthesia care units, surge areas, or the emergency department where there's over 60 patients waiting for an inpatient bed, 10 of them needing an ICU bed, we can't provide that care. We turned down 3,000 transports, patients that needed our help, and we could not accept them because we couldn't take them in. And yes, it's a workforce issue for us at the hospital, but it's mostly a workforce issue right now at the nursing homes, the skilled nursing facilities, and the rehab. And many of us have hired hundreds, and we're at about 450 right now, agency nurses to come in and help, and we're very appreciative of their help. But their cost is typically 50% at least more than what you would pay for a regular nurse. And frankly, somebody that's been with us for 10 years and knows the system is a lot better than somebody that is coming from outside. It's just hard to pick up the nuances of any hospital. So I can say unequivocally right now that the biggest challenge we face at UMass Memorial is workforce. And it's not just workforce in our own hospitals, but it's the workforce in the post-acute care environment. And it is leading for us to a loss of about $15 million a month, something that we cannot sustain much longer. Thank you for the opportunity.
Thank you.
We're going down the line here.
Yeah.
Okay.
Thank you, Andrew.
Yeah, it's great to be here, and I want to thank the Health Policy Commission for their superb work. This is the 6th time out of the 10 years that the Health Policy Commission has been in existence that I've testified at this hearing, and I've enjoyed each one. Seriously. So first, I want to kind of thank my fellow panelists, because especially the delivery system, but also my fellow health plan for the extraordinary work that you all have done during this pandemic and beyond, and especially with the kind of surging mental health kind of experience in Massachusetts. But you asked a question, Madam Chair, about what we should do about affordability, so I want to talk a little bit about that. The workforce and kind of care demands that Dr. Churchwell and Dr. Dixon described are real, and I'm sure we'll hear the same from Dr. Klebansky. But we also have to kind of think about what are we going to do about affordability, because I see a kind of looming crisis in Massachusetts, and we heard a little bit about it in the previous panel. On the one hand, we have hospitals that are under enormous stress and pressure, especially around the costs of their labor, which represent the highest portion of their total spending. The other hand, we have an inflationary environment and a potentially looming recession. As we heard from our previous panelists, we have businesses, especially small employers, who can't bear the increasing cost of healthcare. When the Health Policy Commission started and the legislature set a benchmark for healthcare, it had a lot of impact in Massachusetts. Hospitals and physician practices that came to meet with us, to negotiate contracts with us, would cite that benchmark as something we had to stay below. Now that benchmark is essentially dismissed as not being relevant and not being applicable and not being realistic. And so what we have is we have physician practices and health systems and hospitals asking us in their negotiations with us for 3, 4, 5 times that amount to deal with the kind of problems that Eric just described. And if those increases, if we agree to even a fraction of those increases, we're going to see health insurance premiums grow in the double digits in the next year or two. Today, if an employer came to us and said, we want to renew what's called renew as is, so same employees, same product, same set of services, we on average would offer them an 8% increase in premium based on the experience of the care that our members are getting, which is a combination of the prices or charges and the use of the care. But if we were to agree to increases at 3 or 4 or 5 times the state benchmark that's been established, that 8% will quickly become 10 or 12 or 14. The last time that happened in Massachusetts, the governor of the time called health system leaders like are before you today into his office and said, let's work together to try to do something to promote affordability. And there was a lot of discussion, but not a lot of action. I think now is the time for action. I think given the kind of demands that you have already heard about, and you heard about earlier, we have to come up with better ways. And earlier panels cited some of the collaborative work that this state went through to achieve historic reforms in coverage, historic reforms in changing the way we pay for care. I think we need a similar initiative to deal with the question of affordability. Eric contrasted the US system and what we have in Massachusetts with systems in, let's say, Western Europe, and he's right. But a big part of it, as he said, is the price we pay for care. The Health Policy Commission analysis has shown year after year that we pay more than other states, that we have a relatively consolidated health system, health delivery system, that both here and nationally, that's resulted in higher prices for care. And it's time we thought about that. And the Health Policy Commission has, given its statutory authority, does not have the ability to kind of set prices, and we're probably not there yet. But I think we have to endow this commission with stronger authority in order to kind of grapple with some of these basic affordability issues that are really going to create a crisis here in Massachusetts if we don't act collectively and collaboratively in a way that preserves what's best about our healthcare system, but promotes greater affordability here in Massachusetts.
Well, first, I want to thank the Health Policy Commission for inviting me to testify today. Honored to be here for my first time, so I guess we're averaging 3 years. Andrew's been here for 6. This is my first, but really want to commend the Health Policy Commission on the work you've done over the last 10 years. While I wasn't here for the majority of that, I understand that some really good work has been done to try to control cost in the state, and looking forward to the conversation we're going to have on the next 10 years in the path forward. The way I think about affordability is really in the context of the 3 most pressing needs that we're facing, and we've heard it in the last panel, and we're going to talk more about it here. Affordability is certainly one, but the other is behavioral health, and then the third is health equity. And those three are inextricably linked. Now, if we were just focusing on affordability as a payer, and not to be redundant with many of Andrew's comments, at our organization, we spend close to 90 cents of every premium dollar that goes back out for care, right? 90 cents. And of that, we see 40% of that is for hospital cost. Roughly 16% is for pharmacy or drug cost. And then roughly 15%, would be for physicians. So if you do the math, that's over 70% of the spend that's in those three categories. So any conversation around affordability needs to get, in my view, at certainly the cost drivers, in those elements. With regard to drug cost, we're seeing that as the largest contributor to trend for our organization. Since 2014, drug costs have increased 33%, which is 20 times inflation up until this year. So any work that could be done to address drug cost, and I know there was a suggestion earlier that drug manufacturers and PBMs be at the table, for this discussion, I think would be a good suggestion. So I'll pause there.
Great. A little shift here. Thank you. So also a pleasure to be here. I want to thank everybody for the opportunity. And I just wanted to start by the word crisis. So we've heard the word crisis. It's come up a lot. And I would just say that when I started my job in 2019, I headed right into a crisis. And that was the definition of a crisis. It was COVID. COVID was the crisis. And I would say across the healthcare system, across the Commonwealth, across all the branches, we all sat together almost every day, sometimes every day, trying to figure out how to deal with this crisis. So it was that galvanizing moment when everyone came together to deal with the crisis of COVID. And it was a terrifying time for everyone, particularly those people in the hospitals delivering care. It was a terrifying time for everybody. But it was also, again, an exhilarating time because we were all focused on that one thing. How do we get through the crisis and return to normal? So it is amazing to me that here we are in 2022, and I'm sitting here, and what I'm going to say is we are in a crisis, but it's a different crisis. In many ways, it's worse than before because things aren't getting better. And I would say on behalf of my other providers who aren't here, including those who are here, we're actually at a breaking point and patient care is at the risk of being compromised. And I never thought I would say that, but that actually is where we are. So in the world of healthcare, and this is for providers not only in Massachusetts, but nationally, this is the number one crisis. So what is that crisis? What does that actually look like? I think the breaking point is we have stressed the healthcare systems, the providers, to a point where we actually don't know how to get out of it. So I just want to go through what that means, and particularly what that means for Massachusetts, because we are known for so many things, but one of the things we are known for is outstanding healthcare. Outstanding healthcare. The number of nationally ranked hospitals, the number of scientists, researchers, people who deliver the highest level of care, set the standards, that's Massachusetts. That's why so many people came here to train. That's why so many people are so honored to work in these healthcare systems. So what's the issue now? What's the context? What's the data we're talking about? So you've heard a lot about what these things are. Let me start with the realities of the financials. Inflation is at probably 8.1%. We've never seen that kind of inflation in a really long time. So we talk about inflation. We talked about it last year. We'll talk about it this year. But what it means for all of the providers, and this is, again, a national phenomena, is that the operating costs far exceed revenue. So negative margin is what we looked at. Eric mentioned that in terms of what he's facing every month. This is what's happening all the time. Where's it coming from? Well, so for us, a little over 60% of our cost is labor. And with agency staffing, that's about an 11% increase in cost. That's enormous for healthcare systems. 60% of patient visits are government payers, that's fixed or uninsured. So that's where we are with that. The cost of supplies, drugs, we've already heard about that. And then again, that leads directly to workforce. So being in a healthcare system and working there was a really amazing thing for so many people. So many people came to our hospitals to work there. It was a source of enormous pride, no matter what your role was. But that's not true anymore. People are leaving the healthcare workforce in droves across the country. Hundreds of thousands of people are leaving. So what does that look like? It's burnout, it's workforce violence. I mean, these are the things that we're confronting every day. So we're looking at the people who are providing care every day and everyone else who works in these hospitals. It's no longer considered an honor, and I'll use that word liberally, to work in healthcare. And that is something I've not seen in all the decades I've been in healthcare. So let me move quickly to capacity. Eric mentioned capacity. Kevin mentioned capacity. I just want to put a little point on what capacity is. So there are different levels of capacity challenge. There's code help, there's disaster capacity, there's the whole outlay of what that really looks like. So at MGB, we're above operational capacity all the time. I'll take Mass General. Mass General is in capacity disaster pretty much every day. So in many decades, I've seen it maybe once a month, and everyone would say, wow, that's an incredibly busy day in the ED. Disaster capacity, MGH, every day. That means there's a minimum of 60 patients in the emergency department who are basically admitted with no place to go. They have no place to go. So they sit there, and then more patients come in. And then we have all of the psychiatric boarders who sit there. So this is not going away. And you of course all recognize what that means for patients, for patient care. They come into a hospital, they want to be taken care of, and it's wait in line for the next person who's going to be taking care of you. So our hospitals, our academic medical centers, Mass General, the Brigham, all these hospitals are designed primarily for tertiary quaternary care. They're designed to provide the highest level of specialty care for those people who need those services. And then there are community hospitals, and we have many in our system. There are community hospitals everywhere. But here's the problem. There are no beds anywhere. So about 60% of patients who sit in our AMCs are patients who really are getting care that could be provided in a community hospital. We have no place to send them. So the capacity challenges are everywhere. You can't move people around. You can't put people in lower cost settings. And that also leads me to ambulatory, because Massachusetts is at the low end of the country in ambulatory sites per person. So again, what you want is more sites out there in the community providing lower cost care closer to home at lower cost. And that, again, would make a big difference in lowering the cost of care. And that's very, very hard to do. Just quickly, I'll again go to behavioral health. And I want to just mention the behavioral health crisis in children. The behavioral health crisis is everywhere. We invested almost $200 million in setting up the Epstein Center at Salem Hospital. It's a magnificent facility. It's a magnificent facility. It has beds for adolescents, for children, for adults, for geriatric patients. You should see it, state of the art. When we opened up that center, and it has about 120 beds, I thought, well, this is gonna really make a difference. It was full in a week, because there's a never-ending need for this. And with the help of the state, and I wanna thank Secretary Sutters for this, we've opened up another 124 beds in the last 2 years or so, and that's been terrific. We have over 600 beds across MGB. It's an endless need. We cannot absorb the number of patients who need help. So I just want to put the behavioral health challenges, lack of staffing, post-acute challenges, and last, inequities, disparities, a whole other discussion. But access to care is at the root of equitable care. And those people who come from the most underserved communities have the least access to care. So until we can really fix the access problem, we are going to just perpetuate the disparities in care along with all of the other points made. So there are formidable challenges here. We have to work together to solve them. I'm not pointing fingers at anyone. It's a collective challenge, but we really have to understand the context of what's happening to patients. Because fundamentally, healthcare is about patients. So do we need to lower cost? Absolutely. Do we need to provide the best care for patients? Absolutely. But let's not put that at odds. Those two things need to work together and not be conflicting problems.
Thank you. Very, very helpful understanding the challenges that you're facing and also the issues around affordability and that balance that we've described in terms of the need to fund the workforce, but also to address the concerns of employers and consumers. With that, let me open it up to questions from our commissioners. Yes, please.
Thank you, Madam Chair, and thank you to the panel. You've very succinctly described our situation, and it's not a pleasant thing to hear, and it's certainly not a pleasant thing to live through every day. And so for those of you who are providing care, thank you for showing up to work every day. It's not an easy thing to do. I feel as though it's a perfect storm, and I think you've encapsulated it very well. We know that you're wrestling with acute workforce issues. We've heard a great deal about nursing, but every other clinical profession struggles the same way. We don't hear about the physical and occupational therapists, but they're struggling. We don't hear about the med techs, but we know they're struggling. So everybody out there is struggling. In addition to dealing with the workforce challenges, you're dealing with the inflationary challenges. Dr. Kulinski, you described that eloquently. So given the inflation, given the stresses, given all of the pressures that you're experiencing every day, how do we start to think collaboratively? And I think that question was already asked, but let me ask it again. How should Massachusetts balance the challenges facing healthcare systems and those facing the businesses and the residents? Healthcare insurance is quickly becoming unaffordable. Access issues impact equity issues, they impact poverty issues, they impact environmental issues. Senator Markey this morning eloquently described the relationship between climate change and issues around healthcare. All of these things are impacting us now, whether we like to acknowledge it or not. So how do we balance the challenges that you face, the challenges that the insurance companies face in terms of cost management so that our citizens and the residents of this Commonwealth get care? And I know that's at least a doctoral dissertation.
I'd be happy to start the dissertation. It's a big problem, so there's not going to be a single solution, and I think you assume that. So it's going to take multiple solutions, and let me just suggest 2 or 3 that we ought to think about. One that was cited in the earlier panel is kind of administrative complexity. So that's an area where there's little value and a lot of spending. And Kane was right, there's only 10 cents of every premium dollar is spent on administration of a health plan, but we have certain requirements that cause administrative spending in the delivery system. And so there have been collaborative efforts in the past. The chair was involved with one of those efforts to look at, are there a half dozen or so areas where we could eliminate administrative spending in the system so we could reinvest it in care or perhaps in lower prices. And some of that is starting to happen. One of the issues is that health plans have always credentialed physicians separately, but with UMass, we said, we respect their judgment, and as long as they had the right capabilities and it would satisfy our accrediting agencies, we would delegate that to them. We have, I think it saves us both money. With the New England Baptist Hospital, we've had a very successful pilot where we're using artificial intelligence to power prior authorization approvals. And so things that used to take a week now take an hour. Things that used to take an hour take a minute. And we should all be doing that. We should be deploying technology better in our organizations to reduce administrative complexity. But then I do want to come back to the issue of price and spending, because that is a part of this. And we've had this dialogue, I think Ann and I had it a little bit last year, is I think each of the organizations here are trying to make sure that care is at the right place at the right time. They're trying to actually create efficiencies. But I think my kind of plea would be that I realize that some of that efficiency has to get reinvested back in their organizations in order to fund some of these demands they have, like workforce, but also suggest some of that efficiency should be given back to the community. And the way they share that with the community is by charging lower prices for some of their services and giving them back. And some MGB did as part of their performance improvement plan with this organization. Some the Beth Israel Lahey did as part of their agreement with the Attorney General for their approval. I think we have to look at more opportunities to kind of look at, can we lower prices in a way that we can then share with the community on top of some of these other interventions that I think would save money.
So I would just add maybe a couple of things. One is this right side of care. And again, Andrew, I'm glad you brought that up, and it comes up a lot. I do think it would be worth thinking at a state level how we really provide that. It is an enormous challenge. And speaking to colleagues around the country, they're seeing many small community hospitals going out of business. Mm-hmm. And they are absolutely beside themselves because, number one, it's going to increase the cost of care. You're going to have very routine care come to academic medical centers. Nobody wants that. And as I keep saying, I want a reverse migration. I want all those patients, and I think many of us who really run academic healthcare systems want those centers for what they are there for. It's that higher level tertiary complex care. We send about 5,000 patients away who need to come to us. They need to be taken care of in community hospitals. So again, these challenges are not just in Massachusetts, they're all around the country. My hope, and I'll say it again, because Massachusetts is such a leader in healthcare in every single way, this is something we need to think about at a state level. How do we provide the needs of patients closer to home and do it in a way so that we can lower cost? What does that actually look like? So that's just the first point I want to make. And the second thing I would really emphasize is these workforce challenges are not going to go away, not going to go away. So we're all trying to do what we do. We have a program actually with the league and a lot of community centers and community hospitals and others to look at what the workforce could be. We've invested in that, an equitable workforce for behavioral health, looking at community colleges. Everybody is trying to do something, and they're all great. But it's just not enough. So I would love to see really the state planning for the workforce in healthcare come together and really talk about these challenges, because it has to be broad, deep, and well thought out. So those are just the two things I would add. Kane?
Yeah, what I would add is specific actions on the 80%. So in health, it's well documented that 15% or so of one's health outcomes come from the things we're talking about, kind of clinical outcomes, hospital prices, physician prices, drug costs, et cetera. But there's this whole other 80%, and we talk about it, but rarely is there specific actions that are taken to address food insecurity, housing, transportation, language barriers. And so, we can talk about where the money's going to come from, because I think we would all agree we don't fix the problem by spending more, on those things. We just sort of add to the problem. But improving the health of the population will, essentially bring down overall costs. It's not going to happen overnight, but anything that we can do to drive specific actions as it relates to addressing those commonly known social determinants of health is what I would add.
I'm going to suggest we can come back to this if you want to add other thoughts, but I want to make sure we have opportunity for other questions from the commissioners. If I could move to Commissioner Cutler.
So I actually want to pick up on a theme that's come up, and I like the way that Dr. Dixon phrased it, which is in talking about the cost drivers at UMass, he said there were basically three. There was the administration, there was the pharmaceuticals, and then there was the workforce costs. And so I'm wondering what advice you would give the Health Policy Commission and or the state on all three of those, or any subset that any of you wants to offer. So for example, what can the state do to push more administrative savings? Pharmaceuticals, that may be a little more complicated here, but what can the state do to either increase the number of workers in the short term or reduce the need for workers in the short term so that we're not at such an imbalance? So sort of what can we do and what can the state do on those drivers? I looked at you because you had the helpful description, but it doesn't have to be just Dr. Dixon who answers the question.
I'll start. Well, thank you, Commissioner, for the question. And I think, as Andrew pointed out, and I agree, we don't have a overutilization, except for maybe an imaging in this country problem based on available data. We have a price point problem. And I talked about the three areas where we are just very different from the rest of the wealthy nations in this world. And so at a federal level, I'll always go to Medicare for all. I'm a healthcare socialist at heart, and I think that's where I hope we end up. But you can't do that at a state level. So recognizing that, I would focus on innovation. When the last great piece of legislation that came out of Washington was the Affordable Care Act, in my opinion. And when the Affordable Care Act came out and the Center for Medicare Innovation and ACOs right around that time came out, I said, everything's going to be pushed to the community hospitals. And I could not have been more wrong. And what happened is the way we care for patients changed. So when I started my career in emergency medicine, if you had a heart attack, you got a dose of aspirin, a little morphine, and a bed in any ICU next to a defibrillator. There were no specialized things that were done for you that could only be done at the AMC. Well, today, every single one of those patients is transferred, even if there's a threat of an MI, a consideration of an MI, to the AMC, where they have 24/7 angioplasty with drug-eluting stents. Every stroke, or every possible stroke, most of them aren't even strokes, are sent to a center that can do endovascular retrieval of the clot. And it is completely overwhelming us, as Ann described. We don't want them all sent to the AMC. We want them to stay in the community hospitals, but better than that is to care for them in their home. Two of the best hospital at home programs in the country are represented at this table. And what we have seen in both of our programs is that if we take the lower acuity patients and we care for them in their home, which we can do now because of our monitoring capabilities, our digital medicine capabilities, they don't get pressure ulcers because they get up and walk in their own home. They don't get malnutrition because they eat their own food in their own home. They don't end up in skilled nursing facilities because we fixed the home situation when we were there. And so if we can get programs like that to scale, because they're very expensive at a low number of patients, because you need to have a 24/7 monitoring set up in a mobile workforce, but they actually use far fewer nursing hours per paid patient day once you get them to scale. And innovation has kind of got us into this problem in terms of advances in therapy that are all driving care to the AMCs. And I also think innovation can get us out of it if we can embrace it and push more to the home. And I do appreciate that Blue Cross Blue Shield is talking about, we might not agree on the price yet, but paying for the hospital at home program. And Secretary Sutters has been supportive of continuing the program beyond the current waiver. But this is the future of medicine, and this can drastically reduce cost, at least in the hospitalized environment. And it requires less labor, and less people get readmitted, and less people need to go to a post-acute care setting. This is our best shot. Thank you.
Thank you. Commissioner Cohen?
Oh, sorry.
You want to make one more
Well,
comment?
just two quick thoughts is One, this was discussed earlier, we do need to shift the balance of primary and specialty care in the state. We are overbalanced in specialists, and the governor had a proposal on that. So we could come up with a large community investment in primary care, and that would help us, since 50% of all spending is on 5% of the patients, most of who have a chronic illness. They're not actually the stroke and MI patients. They're the people with multiple chronic illnesses and multiple medications who need to be managed in the community. I also think we need, Dr. Dixon mentioned innovation, and we also have to think of innovation in new ways. We just announced that we are going to have a virtual first primary care offering in all our products with no cost share at all, starting in January. And so for our members who either have no PCP or want to switch to PCP, they can elect to go to this kind of virtual first. We have two kind of newer practices in this area. They're going to have integrated mental health in every case in their practices. No cost share for primary care, no cost share for mental health, not based in one of the large systems with their higher cost burden and therefore higher prices. And so I think we need to kind of unleash some innovation on the delivery system side as well.
Yeah, I would just add that home hospital, I'm glad that came up, very important. It does need to be tech enabled, and that's important, and it does need to be reimbursed, and it does need to be at scale. So I just want to emphasize those points because I think they're really important. Second thing that can be done is to really make sure that telehealth continues. So the expansion of telehealth is incredibly important. So we know that post-pandemic, still about 80% or so of behavioral health visits are telehealth. That's been extraordinary. Primary care and others are starting to drift down. That concerns me because, again, it puts an untoward burden on patients to find transportation, to find childcare, elder care, take a day off from work, lose pay. All of those things are not where we want to be at all for patients. So again, telehealth is really important. The other thing about telehealth, and this is the third thing I want to mention, is the digital divide and who has access to what. So one of the really important things we learned during COVID in going to Chelsea, going to all the various communities where we were really trying so hard to do so much, there were so many people living in those communities who didn't have an iPhone. They couldn't get into Patient Gateway or a portal. There were language issues. So a lot of what we learned was this. Some people did not have broadband access, and I know the state is very engaged in that discussion, and I'm very appreciative of that. That's a very important thing to push forward. For individual patients, you are not going to always have people who can get on a Zoom call or use that platform. So the ability to work on the telephone, the ability to send text messages, the ability to go to different languages, it's really essential for health equity. So again, for access, for equity, for the use of technology, or sometimes it's not even technology, it's lower technology. It's just not available. Giving iPads out, phones, all of the kinds of things that we've been working on in our system, and I know others as well, that will actually help move that forward in a positive way.
So there's a lot of wisdom at the table, as you can tell. And a lot of my colleagues are very much thinking about what solution sets. But in thinking about your question, what could the state do? It's really an issue around how do we walk, chew gum, throw a football all at the same time? And how can the state help us do that? These are really complex issues. And in some respects, the solution sets were probably much more simple than what we're describing. But how can we all work together to do that and have a forum that develops a plan of action that can actually be done? I think is extremely important. And we need the collaboration around the healthcare providers, the state, to make that happen. The classic example is the roadmap that Secretary Sutter created and helped develop. It is a roadmap that we all can gleam onto, evolve and change for our adult and pediatric patients, kids with behavioral health. But it's a great start, right? It's a great start for us. And what we're describing are these all great ideas, innovation, et cetera. I think they'll work, but I can't guarantee it. but the opportunity for us to think through them and coalesce around those 4 or 5 things, right? Those 4 or 5 things that'll push us forward, I think is the opportunity that the state can help us with.
I want to pick up on that. All of you identified behavioral health as a driver of the current crisis that we're facing, the ED boarding, the number of especially children and adolescents that are seeking care. What solutions would you offer to that, short of adding bed capacity, which the state has actually done a good job of? Unfortunately, a lot of those beds are operational because of staffing issues. But Dr. Churchwell, you mentioned a continuum of care. What in the continuum are you looking for that would help your institutions or the payers in this situation further address the behavioral health crisis we're now facing?
When I talk about the continuum of care, I talk about where our kids specifically are engaged and need help, and we can identify that help before they get to us. And so that's in the family home, that's in the home, that's in our community settings, and specifically in our school systems, where our kids are there every day. And our ability to provide support, program, engagement, communication at that level, I think, is profoundly important for us to think about, to think through, and think through what are the programs, the people, the technology, the innovations that will truly help our kids in school. Because our teachers see them every day. They see the problems and they throw their hands up because they don't have the ability to provide support for our kids who have these issues with behavioral and mental health challenges. So if we can help them at that level, I think I personally believe that we would make great strides from that standpoint.
I just want to add, Marty, we've been spending a lot of time thinking about how do we, as a health plan, support our members with mental health challenges. We are, for example, along with Children's Hospital, both invested in and working with a company called Brightline, which has a new model to care for kids with mental health problems that includes coaching, work, support for the family, support for siblings. We're working with some companies that are starting to help individual clinicians with some of the administrative overhead so they can accept more insured patients. And that's been a historic problem. We are trying to pay primary care practices a higher rate. Usually I'm talking not about spending more, but maybe spending less, a higher rate of payment when they integrate mental health care in their practices. That we know that works. We have to do a better job of explaining to practices how they can take advantage of that. We have a very successful program for years in the state where pediatricians can have consults with child psychiatrists. We need to expand programs like that probably on the adult side as well. So I think there actually are, I'm as worried as I am about the day-to-day, I'm actually optimistic that there are a series of interventions we can make in collaboration with the delivery system, with clinicians, with schools, as Dr. Churchwell said, and with the state to kind of at least improve today's mental health challenges.
So maybe to pick up a little bit on the theme of preventive health, what you do, whether you start in childhood or where you are in the cycle, just maybe add in 3 more things that I think could be important at scale. Number 1 is destigmatizing mental health illness. I mean, this is a really important topic. McLean Hospital has done a number of, I think, really outstanding campaigns and work in this regard. But destigmatizing these problems is really so important in engaging children and families earlier, in talking to adolescents, in working through wherever you are. So I would really like to see something that really, really leans in on that, because that is still a huge barrier. There's access issues that we've talked about, but that is a huge issue in terms of not really identifying problems until they're very, very, very far along. So I want to flag that one. The second thing just to highlight is the importance of putting primary care at front and center in this. And I know we've talked about it, but in our primary care practices, we've really embedded so much screening for depression and anxiety, having some CBT tools online that patients can use. These are really important ways to do two things. Number one, it prioritizes the behavioral health issues for patients. They come to accept these things as part of what care is, and that's exactly right. And it also offers opportunities. So I want to emphasize that. The last thing is we know that there are differences between those patients who are struggling with anxiety, the beginnings of depression, and those patients who have severe chronic psychiatric illness. And these are extraordinarily difficult patients to monitor, to take care of, to provide continuity of care. So a lot of the things that we're doing and others are doing related to population health, wraparound services, putting a team around those patients, that's incredibly important because otherwise they're lost to the system and they come back and they sit in the EDs. And you look at the chart, they've been here 100 times before or 10 times before or at someone else's ED. So again, that's a focused group of patients that we should really be concentrating a lot of efforts on. And that's very different from the broader issues.
Yeah, what I would add is, we're certainly focused on whole person health or total health. So we're actually insourcing our behavioral health capabilities so that we can have a 360 view of our members on their needs across physical health, behavioral health, and frankly, socioeconomic or social influences of health as well. And then it comes down, as has been said before, expanding the network, ensuring that there's a broader set of behavioral health clinicians that our members have access to. Telehealth was mentioned. Legislation that allows for behavioral health specialists outside of the Commonwealth to treat members here as one example. And then licensing. There are situations where licensed social workers are the appropriate clinician to treat members. So being, kind of innovative and flexible in thinking. And then lastly, around primary care is really partnering with our health system partners as well as other physician groups to better equip PCPs to deal with behavioral health issues. We operate in 4 other states outside of Massachusetts, including New Hampshire, and I was there on Monday. In New Hampshire, there's really a focus on primary care physicians really leaning in and being willing to not only address some of the behavioral health issues, but prescribe medicines where appropriate as well. So some learnings that we can have there.
I would just say we have a system that's perfectly designed to get the results it gets. We pay a lot for procedures. We pay very little for primary care. We pay very, very little for behavioral health services. And at some point, we need to adjust that fee schedule to better reward the cognitive specialists and less for the proceduralist.
Thank you all. And thanks, Madam Chair. So I don't know if you were here for Governor Baker's comments this morning. He gave very thoughtful, kind of scholarly analyses of what's going on. And
You sound surprised?
not the slightest bit. So correct me if I misquote him, but Commissioner Kreider asked him the question as to why we seem stalled on cost containment. This was in the context of David Auerbach's presentation later, which showed we are stalled with moving away from fee-for-service payment, except for Mass Health. And I guess, so what the governor said was, he paused and then said, I think that a root cause is the RBRVS payment system, the DRG payment system, the fact we're still in a fee-for-service mode, which forces you, the providers, to be in a top-line driven, revenue-driven business model. I guess implying that we're going to be stuck there a while unless we can get away from fee-for-service. I don't want to misquote him, but that's sort of what I heard. Do you agree? And why are we stalled on migrating payment? And would you like to see us move more swiftly away from fee-for-service payment as a way to help solve this problem, give you guys more flexibility, you guys and women more flexibility, and perhaps be able to get a better handle on cost?
Don, if I can just add to that, to perhaps aid in the response. There are systems, hospital systems out there with positive operating margins. I mean, we hear crisis and we are sensitive to all the reasons for crisis beyond inflation and recession and staffing costs and loss of investment income, I would think is a significant issue. Higher term borrowing, short-term borrowing costs are up. COVID relief money isn't there. There's a whole lot of reasons, and we're very sensitive. But that's really pretty much nationwide. I was looking recently at Mayo Clinic's operating margins and Intermountain Healthcare's operating margins. 3.8% up in Q2 for Mayo, 4.4%, which is down for Intermountain. Intermountain embraced a movement away from fee-for-service a number of years ago. More than 50% of their income now comes from prepaid deals and real value-based deals. John Halamka, who has testified in front of the Health Policy Commission, is now at Mayo. 30% of their acute care is now moved to the home setting. 30% for 2023. That's the target for 23. It's like 22% today. These are big. And Eric, you just mentioned, telemedicine, remote monitoring, and digital first. How can we help you? To Don's question, should we try to help you change your business models to get to these kind of results? Positive operating margins rather than negative operating margins.
Well, I'll have a quick stab at it. One thing to remember is geography. Geography is really important. If you look at Mayo, I think many of us know Mayo very well. The main Mayo campus is not in an area that provides a lot of care to communities around them. So again, they rely very heavily on a lot of international, national business that's very high margin business. So I don't want to get into the complexity of the different, the different geographies, the different systems. But so many of the healthcare systems that I know around the country actually are losing money, and a lot of them are now doing it by cutting mission. They are cutting investments in research. They are cutting investments in community. They are concerned about training. So I just want to balance out some of the things that are going on. I agree with your points. We're moving more toward taking more risk, getting out of fee-for-service. It's a transition. It's a transition. So that's where we're moving to. But it is very hard to do anything right now when we're facing massive operating losses. So I don't have the answers. I'm just sort of talking through some of the points.
How can we help? If changing business models is the goal and moving, forget Mayo and the homogeneous geography. And, But Intermountain has moved to risk contracts at an enormous level, and other systems have. Most haven't. I grant you that. Can we help you? Do we reach out together to other states, other hospital systems to understand how they do it? Should we be, we've talked about working together, it's a really nice general thing to say, but how can we be specific about it? How can we help you?
Well, I see Eric has a comment, so I'll go to Eric, but or I'll go see what Eric has to say. But the one thing I would say is, you have to also realize that so many of the patients we see, we're not the primary providers for. So when it comes to those patients where we are the primary care providers, we can move very quickly. But then there are all the patients who come to us where we don't have very much control over that. So I'll just put that out there for consideration. Go ahead, Eric.
Thank you. Well, thank you for the offer to help and for what I think is a great question. The first thing I would say is that if you look at the top performing healthcare systems around the world, countries, they run off a fee-for-service chassis. So the sense that we have to change the payment mechanism and in order to get greater value, I believe is wrong. There's really good healthcare systems that run off fee-for-service and around the world. Now, that being said, I do believe, especially here in America, if you really want to innovate and you really want to try to reduce the administrative burden that's put on your providers, you have to move towards being both a payer and a provider, like Intermountain has done, Obviously, Geisinger has done this for many years. Kaiser would be the role model for all of us that want to go in that way. This sense of jumping from contract to contract, year to year, and taking risk, and you might be in, you might be out. We're going to choose this level of ACO with the federal government 1 year, and then we're not in 4 years. It needs to be hardwired, and I think that's what Intermountain has really done well, is to become more of a payvider, an integrated delivery system, vertically integrated. And that's what's allowed them to do some amazing, innovative things, do more care in the home, worry about the total premium dollar, the total cost of care for that year, for that member, rather than thinking about maximizing reimbursement for any one episode.
Don, to answer your question, I think the governor's right in that we still have a problem that we haven't fully embraced value-based payments. But I guess I would diagnose the problem a little bit differently. We have 80% of our physicians in value-based payments. The problem, I think, is that we were agnostic as to how specialists would be paid into those arrangements. And that's essentially, it's fee-for-service still operating there. And so it's back to this balance between specialists and primary care. So how could the state help? Well, maybe we need to start looking at episode-based payment models or case rates for specialty care in Massachusetts, because Dr. Klebansky said a lot of their patients are actually referral patients. Okay, and so they're not coming through their PCPs. So even if they had risk through their PCPs, they wouldn't be.
Right.
But those referral patients are being paid at very high prices. And that is back to kind of the analysis that the Health Policy Commission has done recently and year over year. So I think we would have to kind of collectively kind of start to ask questions about how do we rebalance primary care and specialty care? How do we empower primary care in the risk-based arrangements? And that's why in some cases we're looking at new entrants in the primary care space who don't have, in some ways, the burden of needing to fund the specialty care at the level at which the large academic systems have. And so we may need some more disruptive players, so to speak, in the system in order to start to see, can we make this work, Chris, in Massachusetts in a different way as they do in Utah or in Northeast Pennsylvania?
Thank you. Secretary Sutters?
Well, I'd love to stay on the disruptive conversation, because I actually do think we're at a point in time in the Commonwealth where disruption to the status quo is what's going to sort of pivot us forward. But at the moment, I'm being a little granular. So I just want a comment to Dr. Klebansky, and it's not a debate, but it's my understanding is one of the reasons why telehealth on primary care is starting to decrease is because the reimbursement changes on January 1st, unlike for behavioral health. So when the legislature passed telehealth, which we did in the emergency, of course, we did parity of both in-person and telehealth visits because it was very important for us to acknowledge to consumers that was not a lesser service. That was very important for people to receive care. But that my understanding is that while telebehavioral health parity rates continue, it does not so for primary care and chronic care as January 1st. That's just a comment.
Yeah. No, it's a good comment.
But I have a question. I actually have a question for my two friends who run health plans, and then a question for my three friends who run, I consider you friends since we get to talk to, every month at 7 a.m. in the morning for the three healthcare providers. So to both Blue Cross Blue Shield and to Point 32, you are, Medicare Advantage is a growing plan, both nationally and in Massachusetts. And I think it's like 8.5% of the population, and it's growing. And since I'm one of those people who's way over the other side of 65, I'm getting a lot of all your marketing materials. Thank you very much. Yeah, it's fine. But I really want to, we're stuck. The entire healthcare and human services system has a throughput issue. We both know that. So I'm sure you saw, so on any given day in the Commonwealth, just say there's 10,000 hospital beds, staffed hospital beds. I'm pretty close. 10% of them are with individuals who are hospitalized awaiting discharge to another level of care. In a survey that was done by the Mass Hospital Association, so it's other discharge planners. So I was surprised. I thought the number one issue was going to probably be Medicaid or transportation, but in fact it was insurance, and it was Medicare Advantage plans insurance, that people who are in hospital waiting for approval for the next level of care, and both of you are innovators. So understanding if there was a bed in the next level of care, so, and there are, I mean, it's not what it used to be, but in fact, prior authorizations and approvals for people to move from hospital to that next level of care and Medicare Advantage plans was cited by hospitals. You're out of this, Dr. Churchwell, right? And so I'm just asking you all, because you're both innovators, what can we do, whether it's using artificial intelligence or other things, to help move people through from hospital to, the acute rehab side on those plans? So I just want to put that forth to the two of you. And
Yeah,
then,
so
and if I
I
can, I'm
mean-
gonna have a quick one for the three providers.
Yeah, certainly leveraging data and analytics, AI, machine learning, can certainly, assist with that. But, as we think about Medicare Advantage and the quality associated with delivering for members in that space, I think that, like you said, analytics, predictive analytics, to understand what the best next source of care for that member would be something that we would recommend. I don't know if you have-
Right, but these are people who actually are waiting for, they have been identified and are waiting for approval.
Yeah,
That's
so
what-
from a prior auth standpoint, and we touched on this earlier, we do believe that there's opportunity to automate prior authorizations. And I hadn't heard this challenge specific to the Medicare Advantage population, but that's something that we would certainly consider and look at.
Yeah, Madam Secretary, this is news to me.
Yeah.
No one's raised it with me. So I am.
I'm sorry to do it today.
No. I'm happy for you to do it, because I want to find out, is it a real problem or is it not? And if it is a real problem, that seems, if there are beds available, rehab and post-acute beds available, and I know that's been a problem throughout the system, but I've not heard about a differential problem with Medicare Advantage patients. And so let's figure out, I often hear about reports of, kind of health plan, kind of bureaucratic problems that exist in the system. And when I investigate them, it's often a different answer. So I'd like to investigate this one.
As I said, I was waiting for Medicaid to be at the top of the list. And
Yeah.
so when I saw the results of the
Yeah.
survey, and assuming it would be transport unavailable being at the top of the list, that it was insurance administrative barriers, delayed response from insurance, and primarily associated with Medicare Advantage plans, I was like, that's one. And then the second one was the lack of guardianship and conservatorship.
Yeah, let us take that back, because as Dr. Dickinson said, is that the Massachusetts-based plans, or is that?
Yep, this is the MHA survey.
Right, but is it, no, but.
Oh,
there-
yes, but then I'd look to the two of you, because you are innovators.
Right, so
As to then how
it may not be a problem with .32 and Blue Cross, it may be a
Yeah,
problem.
we haven't
with
seen,
other-
yeah, that's right. Yeah. I mean, we're
I'm
always
sure it's
looking-
those national
Always looking
plans.
for ways to become, more efficient, but that, we haven't seen those.
And then to my, okay, so I'll just, so now that I've offended the two of you, I'll offend my three other friends. All three of you are large hospital systems, and you're also large provider networks. You have PCPs, you have physician groups. So given the fact that we have such, I know I went granular, I'm sorry. Since we have such emergency department challenges, what are you doing with your practices and your PCPs? And you've all heard me talk to you about this, to deter your patients from going to the emergency department for non-emergency care, for non-emergent care.
So there are a number of things that we're doing. And again, when you have thousands of physicians and healthcare workers who are seeing patients, it's hard to reach every one of them. And we've talked about this. Overall, I'd say we have a very robust plan to move people to different places, get people to use the portal. For example, one of the things I'm really happy with is urgent care on demand. And that's where if something happens, you can actually schedule a telehealth visit on demand for a problem that otherwise would have brought you to urgent care, or in many cases, to the ED. People just come to the ED. They don't even go to an urgent care facility. So that's one thing to do. Getting the triage system embedded as to where you go for what, I think is really fundamental. And I think, as many of you know, back in the summer of 2020, we really reorganized all of hospital operations so that we have one chief operating officer across the entire system, with all the chief operating people, no matter where they are, all reporting up to a single function. That's been really important in rolling out this enterprise asset management, which basically is a single connectivity portal where all these kinds of things can be adjudicated. So without going on, I'll just say there are a number of things that we're doing that basically will prevent exactly what we're talking about that happens every day, and try and help with some of that stress.
Probably our two biggest strategies are, one, we open up a chair of urgent care chains, and we, through our portal, have pushed as many patients as we can to the urgent cares instead of going to the emergency department. Our emergency departments are overwhelmed at this point, and one of the more innovative programs would be our mobile integrated health, which is if a primary care doc has a patient that they're worried about, they're about to send them to the ER, they call one of our paramedic units, they will dispatch them to the house, they'll call the primary care doc back, and if they can manage the patient in the home, we'll manage them in the home, and that's been very successful. The challenge with it, it's not reimbursed, so right now we're just kind of eating the cost, but you're trying to learn as much as we can from it. It's a lot cheaper than taking that patient to the emergency department, so hopefully we'll figure out a way to keep that program going.
Well, we're associated with a very wide primary care practices across the state. And so in doing that, what we try to do is to make sure that no child is more than 20 minutes away from consultation and from support, whether it's from Boston Children's or the Primary Care Network. And so, as you can imagine, that communication is very strong between the groups that we support and what they do every day. And so it's been, for a long period of time, the encouragement of not coming to the specialist or not coming to the academic medical center. How can we prevent that from happening? How can we support that in the primary care practice? For example, with behavioral health, we've worked with our behavioral health programs and offices to embed primary care expertise within their groups, whether it's a psychologist or a social worker, so that that expertise is there and we can get to the child immediately. Another example are the referral or consultation lines between our primary care practices and our specialists, where instead of just, well, I have a child who has this, I'm just going to send them in. The first step is to make the phone call and talk about, what needs to happen. Can it be managed here when it cannot be managed? And so we work pretty diligently on that in terms of having that type of communication. Communication, I think, is the key component of that type of that piece of work.
Thank you so much. We'd like to pose one closing question. Can't resist. If I can ask you, Commissioner, to ask our final question.
Yep, thank you. Sometimes I feel like I have whiplash in these meetings when you go from this atmospherics to in the weeds and then back out again. So I think it'd just be helpful as we close out this panel, and it's been asked in certain different ways throughout the course of this discussion, but just to close out with just your final one or two areas that you believe that working together and collaborating, what one or two issues would you want to collaborate with the Health Policy Commission on to address our common goals of reducing the cost of healthcare and affordability in the state of Massachusetts? So just one or two things that you think we could be doing better together with the HPC and the collaboration. I think it speaks to what we've been saying, that we all want to come together to try to solve these problems. So I think it's a good way to close this panel, just to, again, identify one or two areas that you think you would want to collaborate with the Health Policy Commission and others to try to reach our goals of affordable healthcare in the state of Massachusetts.
Yeah, well, I was going to say, I think the area of health equity is an area that we can lean on together. You know, every one of the organizations represented on this panel has health equity initiatives. The Health Policy Commission has health equity as a focus. Convening collectively to discuss, again, specific actions that we can take in specific areas. Health equity is such a broad category. Social determinants of health is a broad category. But ensuring that we're aligned in terms of the initiatives across the Health Policy Commission and the organizations represented here would be one.
Well, I definitely agree with Kane about health equity and how do we also link that to access, which is something I've mentioned a number of times here, because again, access to equitable health care, that's a sentence. And I think we ought to look at it as the same issue or one and the same issue, equitable health care, so access. So I would say that. I think the second thing is dealing with these capacity challenges. They are really only accelerating. And I worry very, very much about the livelihood of healthcare in this state. And, you know, as I mentioned before, I really do think it's at a breaking point. I'm not really someone who uses hyperbole, for those of you who know me, but that's where we are. So when I'm seeing hospitals and healthcare systems losing hundreds of millions of dollars, I'm really worried about what it is we're going to be investing in all of these things we want to be investing in. So I think one of the challenges in thinking about the benchmark, and we are on the PIP, as you know, and we've been working very hard, and I appreciate bringing that to a point where we are. We've identified savings, we've identified opportunities, but I really would worry about what the benchmark means in this particularly fragile time. We've done a lot to make healthcare more affordable. I know this strays from your question, sorry, but we've done a lot and I'm very proud of it. We should all collectively be proud of it, but this is a very dangerous time for taking care of patients. And I really just feel I would be remiss on speaking on behalf of patients if I didn't end with that, because that is the kind of thing that worries all of the providers.
So I'll mention two issues. I'll reinforce on equity. We're the only plan in the country that I'm aware of that has done an audit of our own equity data, published it, provided all our physician practices with their equity data, gave a $25 million grant to the Institute of Healthcare Improvement to work with those practices to improve. And now we're going to build equity measures in to our value-based reimbursement system beginning in 23. I want to kind of maybe do a little counter to Ann here, because I think the issues she said are real. So let's assume for a second that health plans and the state have to pay a little bit more, let's say over the next year, because of the inflationary demands that the hospitals are facing. So let's just assume that. But let's make it a one-time issue. So how can we work together? Let's not build whatever additional spending has to be done to help stabilize the healthcare community and healthcare organizations, especially actually not the ones represented here, but the smaller, less stable institutions. But let's not build it into the base of health spending in Massachusetts. We already have the highest per capita health spending in the world here. And if we kind of have this crisis, this real crisis, I want to validate that it's real and build it into the base, we will never be able to recover from that.
I'll finish where I started. We all want the same thing. Better care for the people of the Commonwealth, regardless of the color of their skin, their gender identity, or their sexual orientation. And that's only going to happen by working together. The providers can't do it alone. The payers can't do it alone. The executive branch can't do it alone. And so I think the opportunity to meet more regularly together, but talk about solutions and flush those out would be something that I would really welcome. Thank you.
Well, I think you made a little progress here. And I think it's worth a continued conversation about how do we get to a true solution set. The question around what you could help with, it's been mentioned in terms of workforce, in terms of the issues around behavioral health. I just want to close by just making a comment about health equity. in that there was a great discussion at the last panel around health equity, and I'm sure across throughout the day. The only point I would like to make is that if we try to solve health equity by itself, we're not going to solve health equity. If we work on health equity as a component of equity, educational equity, economic equity, then I think we have a chance. And so to bring it in the broader text, I think is the opportunity for solution sets for that.
Thank you. Thank you so much to our panelists. I think I'll echo what we heard from many of you around the common themes that will bring us together, being addressing equity, access, and am very glad to hear that each one of you understands the commitment to affordability as part of the solution to that, and needing to work together. So we appreciate your attendance today, and we look forward to that shared responsibility and working together. Thank you. Now going to take the last 15 minutes of our time to ask each of our commissioners to share a moment of reflection and comments on the hearing to close us today. So if I could turn to you first, Commissioner Cohen, to share your thoughts.
Sure, thank you. And my thanks to all the speakers and the witness panels today. There was a report issued last week from Mathematica, which talked about the success of the Health Policy Commission's work to address costs. And when it talked about the cost trends hearing, there was a comment there that said, oh, the witnesses just tell the commissioners what they think they want to hear. I don't think we heard that today. So I think it was a real honest and thoughtful discussion. In my field, philanthropy, we have a term called collective impact, where folks come together to address a social need. And I heard the word collective or references to things like collective several times. Dr. Kloblansky talked about collective challenge. Dr. Richman talked about collective agreement. And Amy said shared responsibility. I think we have an opportunity here to really come together in a different way. I think it's been providers and payers and government, but I think we really need to come together around the recommendations that were in the cost trends report and really think through some of the issues that were just talked about in this panel if we're ever going to address healthcare costs, which we need to, because I think the data that was presented shows that for low income and now middle class folks, for people of color, healthcare in Massachusetts has become unaffordable, and we need to address that.
Thank you. Secretary Sutters.
Sometimes I think I'm just like the skunk at the garden party. So I honestly do believe that we are at one of those tipping points where we have the opportunity to bring together the payers, the providers, all of us, government, and the voice of consumers and with our colleagues in legislature on a different path. 10 years since the original law passed provides that opportunity to not just reflect, but how we move forward. I think the challenge is, can people really put, I always learn something. Can people really put, honestly, like the 2, 3, 4, 5 core issues affecting cost that does not compromise quality and improves access equitably on the table? The other thing is I just have to say that I sort of missed having a conversation about pharmacy, because the pharmacy is currently the number one driver of healthcare costs. It was a missed opportunity, but for many of you, that'll be this time next year. So thank you for that.
Thank you. Sure.
Yeah, The one thing that keeps coming to my head, two things that really stuck out through this whole conversation was this issue of, two things was hearing Amy talk about the health line and the stories of the unaffordable healthcare that folks are facing and what that means for families. And David Auerbach always gives that slide with the car and just sticks in my mind every single time. And then the second was Dr. Kablansky when she was talking about the capacity and workforce issues at Mass General. And I forget the code that they use, or like disaster.
Code disaster.
Yeah,
Daily
and
disaster.
yeah, just, so I feel like there's this brewing debate about we can't do anything on affordability because of the two crises that we're having. And I feel like that's a false choice. And I feel like that's the narrative that I'm walking away from here is if we're gonna solve these issues that are real, the crisis of affordability for patients and consumers and the issues of workforce and patients and getting access and the boarding and the lack of capacity, we have to figure out a way to address both of those things. And I feel like they're being set up against each other and that you can't do one without dealing with the other, and that they're at odds against each other. And I think that's a really concerning dynamic that I took away from this hearing, and how we as the Health Policy Commission and others in this field work to figure that out, I think is going to be the most important thing going forward.
So I enjoyed this, as I always do. I guess I've been on the commission for the 10 years, and so I feel like we've gone through a few phases. So we first had to like set up things and like figure out what it meant to have a benchmark and adjust to the benchmark and so on. That took us a couple of years. And then everyone said, fine, we'll adjust the benchmark by merging with each other. So that took a few years to sort of work its way through, or not through, as the case may be. And then we had a couple of COVID years. And then I think where we've come to is, at least where I've come to, is a realization that we have to focus even more than we have on how do you take costs out of the system, not just how do you create the incentives. So we tried creating the incentives, which had some impact, but not as much as we wanted. How do we keep furthering our efforts to take costs out of the system, price as well as quantity? I wasn't convinced that we shouldn't deal with quantity issues as well. And so I think now that we're coming out of COVID is the time for us to say, how do we, basically, what can we do along the 4 or 5 different dimensions that will be important to really take costs out, and to say, how do we commit to a path to doing that? Because the issues are getting very, very acute now, both in terms of care quality and in terms of cost for people, in terms of what it means. So I'm sort of the view that that's where, in my mind, I want to go.
Thank you. Can I turn to you, Commissioner Blakeney?
Sure you can. I guess several things come to mind, but one first statement is a very wise person once said to me, never let a good crisis go to waste. And it's clear we're in a crisis. We're also, as an organizational structure, healthcare organizations, all organizations are in a frozen position or they're in an unfrozen position. What's driving us, I think, to an unfrozen position is the crisis. And that is an uncomfortable feeling. It's always an uncomfortable feeling to feel the ground underneath you moving. But it gives us the opportunity to get disruptive. And we've had that word several times before. You know, Clayton Christensen talks about disruptive innovation. It's worth looking at how do we use this unfrozen position out of necessity to look at ways to drive down costs, to increase access, and to get people to the places that they need to be when they need to be there. So I think we've had a wealth of insight and information sharing today. I look forward to us taking the time to really go through this and analyze it and figure out how we allow today's work to inform the work of the commission going forward. I was very pleased to hear about the equity issues. I was very pleased to hear about the commitment to building care networks around patients. The one thing I would offer about that is social determinants of health are not all about healthcare. They're about other things. And if we don't make the people who know those other things part of our healthcare network and part of our team that we surround our patients with, we're losing opportunities to build. So that's the thing. And then from a very personal perspective, as a nurse, I have to tell you, I'm scared to death for my colleagues. I have had dear friends who are some of the best nurses I could ever identify leaving because they just can't do it, leaving because they're so frightened, they're so exhausted, they're so beat up. 20% of the nursing workforce is over the age of 60. Nurses working in a hospital on a regular 12-hour shift lift and move 2,000 pounds a day. 60 years old, lifting and moving 2,000 pounds on a shift on average. Pediatrics, it's a little less. Behavioral health, hopefully it's none at all. But the bottom line is, I know about nurses. Other people know about med techs and physical therapists and occupational therapists and dentists and hygienists and speech and language pathologists, all of whom are part of our healthcare system, all are part of the work to provide clinical care. And if we do not pay attention to what's happening to them and try to figure out within our system how we create policies, how we look at incentives, and how we create disruptive innovation to improve the environment in which all of those folks work, all of the other conversations that we're having will not go very far, because we can build as many beds as we want. If we don't have the staff to fill them, all we've got is a bunch of empty beds. Thank you for letting me do my little editorial.
Thank you. Dr. Berwick?
Thanks, Madam Chair. As always, I enjoyed the day. So for me, the mental model is listening to panel 1 and then panel 2. You really set it up beautifully. And I'd say there are 2 pots. One is where I sense consensus, shared will, a chance to move together, in which the kind of let's all do it together stuff seems to be very hopeful. So the categories I wrote down, everyone's agreed on equity. Let's make this Commonwealth a place that shows the country what true equity looks like in health and well-being. We can do that. We want to do it, and we could get that done. Behavioral health is an emphasis. The Commission's been all over that. We hear the providers, everyone's talking about that. So also very promising area if we can just keep working at it. The third is pharmacy. That's an external enemy, an external threat is how people are framing it. So we need to get to work harder on controlling drug costs, and the prices I'm seeing they're not acceptable in public policy. And if the industry can't regulate itself, it has to be regulated, and we need to do that. Fourth is administrative costs. We've talked about that for all the years I've been on the Commission. We have not yet solved it. Everyone says it's free money lying on the table, and I think we should go for it. And I think the Commission has it in our screen, and I'd say let's move on it. That's just waste. And Dave Cutler is the world's expert on that, and I think can help us a lot to guide us with his research. And the last area is workforce, unsolved, very serious. Nobody's got an interest in a distressed workforce, and I think we should get together and figure that out. And it isn't going to be just pay. We're not trying to hear about payment levels. It has to do with other conditions of work that I think we could work on. So we agree, kumbaya, panel 1 and panel 2 could get on the same boat, but we're not containing costs. And I don't hear a pledge from people who give care to reduce cost. And I don't think it's going to be a self-regulating problem. I think our Commission has come to the legislature requesting more authority and more teeth. I don't think we can help if we don't get more authority. And I'd love to work together with the legislature to change our statutory purview so that we can deliver what you want us to deliver on. Without that, we can't get there. And I don't hear a promise from the delivery system that they're going to solve that problem. And we heard the pain from panel 1, and I feel it. Well, I want to make one other kind of sidebar comment. We didn't talk about quality today. That's my field. This Commission's not just supposed to look at costs. It's our number 1, but subject to a constraint, which is the quality of care be not just maintained, but improved. In the lexicon of quality, that's one way to save money. And at some point, I'd like us to dig more deeply into reducing defects in care, improving patient safety, doing some of the things on quality that we ought to be watching as well. But that's for another commission meeting. Thanks a lot, and thanks for your chairmanship.
Thank you. Thanks so much.
I'd like to begin by thanking the HPC team. Great job putting all this together. That was not easy and in a short period of time. What I found very interesting was our keynote bringing up the point where a firm, a self-insured firm, invites their employees to have access to a system that's out of the state that impacts the cost within that state. That is a really interesting, I was totally not aware of that. That's an interesting opportunity and something that we should all be looking at even more. And hearing the first panel, and I agree with everybody here, it's how do we really start focusing on that, giving people equal care, equal opportunity to care. It's just something that is very difficult, and how do we actually get there? And looking at the second panel, what we didn't get into, and it sort of relates to what Dr. Berwick said, I was thinking about, we're talking about all these future things that we can do. They're going through a process right now where I assume they're cutting costs. How are they cutting those costs? What are they cutting, and how will it impact the quality of our care? And it's just not something that came up. And to reiterate what Dr. Berwick said, they're not in a position where they're going to look at what our objective is in terms of annual increases. They're looking at their own survival and how they're going to make their numbers. And that's something that hopefully the legislature will help us with, to give us a little more clout so that we can place more pressure on them. Thank you.
I was struck by what Michael Curry had to say about, in order to achieve equity, you had to hire the right people and get the right people into the system. And I think one of the chronic problems that we have is that we don't have the underserved community seeing providers that look like them, that talk like them, that understand their culture. And I don't know how we solve that issue in this room, but we need to target recruitment into the medical field from those populations that have been underserved, in order for those members of the community to feel more comfortable, to feel heard, to speak the same language, and to make the access truly equitable.
First, touche, Don, for bringing up the Q word. It is, I think, better healthcare is less expensive if we focus. I mean, I'm a one-trick guy, right? It's about it's about focusing on the outcomes and creating real accountability up front, rather than on this ridiculous back-end system that we have. I think we, the Health Policy Commission, and the staff have to be very careful not to be self-congratulatory. There is a big problem right around the corner. I mean, we are going to have bankruptcies in this state in the next quarter. It's going to happen. I mean, if somebody has arguments that it's not going to happen, please make them. But we have to do something. And we, as a Health Policy Commission, don't want to be, I think, in a position where we are reactive to the problem getting worse when we know it's coming. I mean, there isn't anybody that testified here today that said it wasn't coming. I mean, it was bad, worse, a couple of glimmers of light. But we have to be, I think, more thoughtful, more active, more engaged, more responsible. And that sounds officious, but I don't mean it to be, because I'm part of it too. How can we all help?
Yeah, I think we're fortunate being in Massachusetts. We've made great strides in behavioral health investments. I think we did a lot better on COVID response than a lot of other states. Transitioning away from fee-for-service is going, generally speaking, better in Massachusetts than in many other states. And we've got a lot of great success stories with the Health Connector and the existence of the HPC. But I think, to Dr. Kreider's point, there is a lot of work left ahead of us. I think we're all fairly on the same page of what we we saw today, what we talked about today with health equity, drug costs in particular, very much concerns me. And I think there's some additional opportunities in the areas of telehealth and home health care. So I think we need to continue to prioritize those moving forward and continue to engage with stakeholders. And one thing that stuck out to me, to your point earlier as well, was Colin had mentioned user expertise and engaging the people all throughout our system, whether they're patients, providers, but the people that are most familiar with the system, not just the people that design the system. So continue to prioritize those as well.
Thank you. And Eric or Ray, any closing comments for us?
I guess I would just point out, I was pleased to see the word innovation come up a lot towards the end of the conversation, because I do feel like the problems we're confronting now feel maybe more intractable than they've ever been. I mean, healthcare costs are larger, as a portion of our economy than they've ever been. The cost increase pressures are acute because of COVID and other things. The system itself is very fragile, so just leaning on the provider organizations to solve the problem doesn't seem to be a solution. So, as Matt Damon said in The Martian, we're going to have to science the heck out of this. I think that we're going to have to innovate the heck out of this. I think that the just standard approaches aren't going to get us there. And I think that innovation can take many forms. Massachusetts has long been a leader. It can be business innovation, legal and policy innovation, technical innovation, but I don't see how using the standard levers we're going to get out of the really intractable dilemmas we seem to be facing. So I think something new is going to have to happen for us to get to where we want to be.
Thanks. I'll just share a few priorities that I heard that I think are consistent with what everyone's saying. And the first is health equity and really addressing the social determinants of health, like Michael Curry said. The second issue from the consumer perspective is affordability, and that's the slides from the staff and the calls that Amy from Healthcare for All shares. We know healthcare is too expensive for too many. And just the last priority, I think, is what this commission's been working on for years, and that's, as Professor Cutler says, how to get costs out of the system. And we've known for a long time that prices are important, and this is a crisis time, but continuing to keep our eye on the ball on that. Thanks so much.
Thank you. I really appreciate the opportunity to get together in person this year. I think the dialogue was richer because of the fact that our panelists agreed to come in person and that all of you agreed to attend. So I want to thank you, and also to thank my fellow commissioners for, I'm the newest member of the commission. I had always had a tremendous respect for the work that's been done by the Health Policy Commission, but I have to say that I now more fully appreciate your service to the state and this productive discussion, having been able to immerse in what it takes to both prepare and to make recommendations about these issues. Let me ask you, Director Seltz, whether you have comments for us before we close.
Well, I would just like to say thank you, Chair DeVoe, for your leadership and for your partnership, for designing and implementing and really spearheading an incredible 10-year cost trends hearing. It's just been such a pleasure to work with you the last 2 months. Feels like 2 years /20. And I think on behalf of all the staff, we are just so thrilled to be able to partner with you and with every commissioner here on these incredible challenges. So first of all, thank you. I want to thank the witnesses who are here and who testified, of course. I want to also just quickly thank Ray Campbell. Ray is going to be leaving his position at CHIA soon, and he has just been such an incredible leader of CHIA. CHIA is just an absolute jewel in Massachusetts, and the data and analysis that we bring to these cost trends hearings would not be possible without you and the work of your team. So thank you very much. And also, these hearings would not be possible without the work and dedication of the HPC team. So thank you to the HPC team, Colleen Elstermeyer, particularly. And we have some big work ahead of us, and I look forward to it. Thank you, Chair DeVoe.
Terrific. And with that, we will adjourn. Thank you.
Great job, Priscilla.
Nice to see you live and in person.
I got to talk about you.
Yeah, we think we sobering that without a stronger role for us, price control isn't going to happen.
I thought they were great, but
Another one down,
They're
Dave.
making one-time payments. But we're going to have to. No.
Yes, it was.
Not at all.
Most enjoyable one of them.
Good to see you.
Thank you. Yeah, I really appreciated your comments. And,